कविता सब
कविता, आप दोनों कहाँ पे घूम रहे हो? वर्षा, आई एम मिसिंग
जम्मू जम्मू
जम्मू में. आई एम मिसिंग वर्षा एंड कविता देयर. हाउस द वेदर देयर? मौसम कैसा है?
बाय बाय, एंजॉय.
इनको देख के मौसम कैसा है पता चल जाता है.
एवरग्रीन ऑलवेज. गुड इवनिंग
डॉक्टर भावना.
हाँ भावना, कैसी हो?
ठीक है.
हाय भैया, लव यू ऑल. भावना, अरे क्या बात है. कुंदीर, आवर फेवरेट यूके गर्ल. गुड. नाइस टू सी यू ऑल. ओके, सॉरी टू डिस्टर्ब ऑल. अभी शुरू होने वाला है.
2 minutes में वर्षा, तब तक you can chit chat, no problem.
Can we start, ma'am? It's 4:30 now.
4:30 हो गया तो बिल्कुल शुरू कर दो.
म्यूट किया मुझे, ठीक है.
किसी ने म्यूट नहीं किया भाई.
I thought it was at 4 and I came at 4, you know.
So a very warm good evening to all respected panelists and delegates, and good morning to our panelists in UK. This is Firoz Khan from Team Walter Bushnell Marketing Team. We welcome you all to this Indo-International Web Series 12th in edition in association with RCOG Indian Liaison, presenting a live webinar on Theme-Obstetrics Drill Part 2. I'm sure it's going to be a great knowledge dissemination program. So without any further delay, I would like to call upon Dr. Jyoti Malik ma'am, who is the Medical Superintendent, JJ Institute of Medical Sciences, Bahadurgarh, to take this scientific session ahead. Over to you, Jyoti Malik ma'am.
Thank you so much. Thank you, Walter Bushnell. And as usual, you have been a great support for this Indo-International web series, which is the 12th series today. And this is in association with the RCOG, that is the India Liaison Group. We are today, the theme is the obstetric drill part 2. So part 1 had been great, and this would be greater, I suppose. And for all this, for everything, I owe it to none other than Dr. Lakshmi Srikhande and Dr. Jyotsna Putty. Dr. Jyotsna is our international coordinator, and Dr. Lakshmi is our Indian convener. And first I will go over to Dr. Lakshmi, who is the chairperson-elect of ICOG, who is also a national corresponding editor for JOGI. She is National Corresponding Secretary, Association of Medical Women, and founder patron of ISOPA Vidarbha chapter. She is also the chairperson of IMS Education Committee, and I can go on and on because she has received so many awards and she has been doing so much of academic work, and all this is thanks to her. And for your kind words, Lakshmi ma'am, over to you.
Thank you so much, Jyoti. And I wish to mention that it is your brainchild, and yes, I am executing your brainchild with the help and support of Jyotsna. So it is all Jyotsna, Jyotsna and Jyotsna. So without wasting time, let us invite Dr. Jyotsna Pundir to share her views on this series and as well as to introduce today's theme.
Yes. So Dr. Jyotsna, I would briefly introduce her because she doesn't want to, want to hear so much about her. So she's given just us 3 lines, that she is a consultant gynecologist and a specialist in reproductive medicine and minimal assist surgery at St. Bartholomew's Hospital, London, UK. She has trained at UK's prestigious fertility hospitals, including the Assisted Conception Unit at Guy's and St. Thomas as a clinical research fellow at the Center of Reproductive Medicine and Surgery at St. Bartholomew's Hospital, London. Now, she is very, very passionate about delivering safe, effective, and evidence-based medical care to the patients, and also very keen to educate, empower, and involve couples in decision-making. And not only that, she is very passionate to teach across globes. And that is why we are here in association with the RCOG India Liaison Group. And over to Dr. Jyotsna for her words of introduction and wisdom.
Oh, thank you, Lakshmi, and thank you, Dr. Jyoti.
we started, as you all know, very slowly, and now it's picking up the pace. And I'm blessed with hundreds and hundreds of specialists of Indian origin who are based in the UK, who are so talented and who are so dedicated that they're giving their time on the weekends, and just to share our knowledge and understanding with our counterparts in India. This forum is to share our knowledge to improve the care for women. And this is such an honor and pleasure to introduce Dr. Nutan today, who is known to deliver these obstetric drills nationally and internationally over the years. And you had enjoyed one session from her recently, and I'm sure this is going to be another excellent one. Back to you, Jyoti, to introduce Dr. Nutan. Thank you.
Yes, thank you so much, ma'am. And we have Dr. Sushma as our national coordinator for India, who is at Savodya Test Tube Baby Center and Raipur. And she would be joining us soon. And then we have our convener. We have Dr. Nutan Mishra, who is currently...
Jyoti, you introduce the chairpersons and chairpersons will introduce us.
Okay, ma'am. So before that, I have a duty to introduce our chairperson so that Dr. Nutan can be introduced by them. So we have Dr. Neha, who is the secretary of Ratlam OBGYN Society and who is also a consultant, Ankur Hospital, Ratlam. And then we have the other chairperson, Dr. Alka Kuthe, who is a consultant obstetrician, who's LLM in criminology and human rights, and who's national coordinator of FOGSI Ethics and Medical Legal Committee, who has also been the past president of this association. And she's also a founder member and national secretary of the Human Milk Banking Association of India. So over to the chairpersons, and I would request you to please introduce Dr. Nutan so that we can kickstart our program.
Yeah, Alka, are you there? Alka?
Dr. Neha.
Neha wanted to introduce. Alka? Yes, I am here. So thank you very much, Dr. Lakshmi, Dr. Jyoti Malik, the main conveners of this grand event. Thank you, international coordinator, Dr. Joshna, who is very much famous in India because of her lectures, and of course, Dr. Sushma. So I would like to introduce Dr. Nutan Mishra, who is the opening batsman of today's webinar. She is currently working as a consultant in obstetrics gynecology for the last 9 years at Works Healthcare Center, NHS Trust. Her main interest is high-risk pregnancy, particularly pre-eclampsia, growth restriction, diabetes, and perinatal mental health. She is very passionate about antenatal care and childbirth, which is the core skill we day-to-day in our medical practice. She's actively involved in teaching and training, and she's an accredited colposcopist as well. She's examiner for Part 3 MRCOG and also examiner for Oxford medical students. She's facilitator for basic surgical skills course, MRCOG Part 3, OSCE course, and she regularly teaches CTG and obstetric emergencies in her department, and obstetric lead for clinical governance. This is very important, clinical governance. She has written book chapters on postpartum hemorrhage and rupture of uterus, which are the nightmares for all of us. And she's a voluntarily facilitated course on basic emergency, voluntarily facilitated. Again, this is very important biodata. Obstetric care and newborn care is run by Liverpool School of Tropical Medicine, and she's a consultant there also. So it's a great speaker, Dr. Mishra, amongst us to deliver a lecture. I request her to talk on eclampsia and pre-eclampsia eclampsia. And before that, I would like to thank Dr. Lakshmi, especially Dr. Lakshmi and Dr. Jyoti for involving me as chairperson. Thank you very much.
Thank you, Alka. Welcome, Nutan. Yeah.
Okay, thank you, everybody, and thank you for such an introduction. I'm just going to share my screen. Just give me a moment. And can everybody see the screen?
Yes, ma'am. The screen is visible.
Yeah, we can see.
Yes, we can see.
Perfect.
Okay, good afternoon, everybody. I'm going to talk about preeclampsia and eclampsia, and because it's one of the 3 leading causes of maternal morbidity and mortality worldwide. There's significant differences in the mortality rates across the globe, and that is mainly due to developing countries having, firstly, universal access to prenatal care, access to timely care, development of our day assessment unit, and implementation of formal guidelines. There was an Embrace report in 2000, which was a report from 2009-2012, which looked at all the maternal deaths. And deaths due to preeclampsia and eclampsia had decreased significantly over the past 5 years and was the lowest ever recorded in that report. However, 1 in 400,000 women giving birth in UK still die from pregnancy-related hypertension disorders. And the major failing was thought to be inadequate treatment of hypertension resulting in intracerebral and subarachnoid hemorrhage. So eclampsia, it is defined as 1 or more convulsions in association with preeclampsia. And preeclampsia is defined as new hypertension over 140/90 in more than 20 weeks pregnant with significant proteinuria, and significant proteinuria being protein of 1+ on urine dipstick or PCR more than 30 millimoles in a PCR. Now the fits, they can be antepartum and intrapartum, but we can see that over like half of them is postpartum. So we have to be careful postpartum period as well. And eclampsia is related with high rates of maternal complications and perinatal mortality. Most common cause of death, as we discussed earlier, is cerebral hemorrhage. Eclampsia typically will present with generalized seizures, and most of them are self-limiting and resolve within 90 seconds. That's what we see generally in the UK. I know in India, you can see they have had multiple seizures before they present to the unit as well. So I'm just going to unshare this screen and show you a short video, and that will, so can everybody see that? I'm going to just put full screen. Can everybody see that?
No, ma'am, it's not
yet.
visible.
Not as yet.
No, your screen is not visible.
Okay, sorry. Okay, so that's fine. We should be able to see it now.
Yeah, now it is okay, ma'am.
Now it's okay.
Okay, fine. So we'll just play this
has
short
presented
video.
to the obstetric unit believing she may be in labour. This is her first pregnancy and she is 39 weeks pregnant. She has been well throughout her pregnancy, however over the last few days she has noticed increased swelling in her ankles and has abdominal pain and a headache today. Therefore, the midwife has advised Rachel to come into the unit for a review. Her COVID-19 status is unknown.
Hi Rachel, my name is Jane. I'm the midwife who's going to be looking after you. Tell me what's been happening.
Oh, I'm just feeling really rotten. I've had this awful headache and I thought it was going to go, and I've just woken up today and it's still there.
Okay, and it's your first baby, is that right?
Yeah.
I'm just going to have a feel of your tummy.
Yeah, that's fine.
Do you know what you're having?
Little girl.
Oh,
I feel really strange and
okay.
yeah, just not myself.
Well, let's do a full assessment. Oh, that's beautiful. Let's measure you. Okay. I'm going to put the fetal monitor on to monitor the baby's heartbeat.
It's just horrible, this headache.
And your eyes are okay?
I feel all right, maybe a bit blurry, but...
Your temperature's okay.
Great.
What I might need you to do at some point is do a urine sample for me. Just check your blood pressure. It's 165/110. I'm going to press the buzzer and ask my senior midwife to come in.
Hi, Jane.
Oh, Sophie, hi. Rachel, this is Sophie. I'm just
Hi,
going to tell
Rachel. I'm
her.
Sophie, one of the doctors.
I'm just going to tell her all about you.
Yeah.
So this is Rachel. I think the situation is she's developing preeclampsia. Her background is it's her first baby. She's 39 weeks pregnant. She's had an uncomplicated pregnancy up until now, and then felt really unwell yesterday, didn't you?
Yeah.
And a headache sort of developed, and she's got a little bit of discomfort up here, and her ankles are quite swollen. So the assessment is, I've done an abdominal palpation, and her fundal height is 36 centimetres.
Okay.
Her blood pressure is 165 over 110. Okay. I haven't been able to get a urine sample yet. My recommendation is, Sophie, I think if you could do an obstetric review, I'll put a cannula in and do some bloods. Is that okay?
That's great. As Jane mentioned, your blood pressure is quite high. I think we're going to need to get that urine sample. Jane, if you could put a cannula in and take some pre-ET bloods, FBCUs and these LFTs, and we'll take a group and save as well. So we just need to check your blood tests to see if there's any changes on that. This looks like, as Jane mentioned, it might be something called preeclampsia, which is a condition of pregnancy. We just need to manage it with some medication to help lower your blood pressure, and that should make you feel quite a bit better. Do you have any medical conditions or any allergies?
I'm asthmatic.
You're asthmatic?
Yeah.
I'm just going to have a little feel of your tummy. Is any of that sore?
It's just up here, that wasn't a problem earlier.
I'm just going to test your reflexes. So just going to hit your knee with this little hammer. It shouldn't hurt, okay? Okay, so a bit brisk. So Jane, after you've popped that line and taken those bloods, I think according to our management of severe hypertension algorithm, because Rachel's asthmatic, we should start by giving her nifedipine, so a 10 milligram capsule, and then we'll recheck the blood pressure in 30 minutes. Okay. We can give some paracetamol for your headache as well, and we're just going to carry on monitoring your baby at the moment while your blood pressure is quite high. Okay.
So the cannula's in, Sophie, and I've taken the PET bloods.
Brilliant.
I don't feel well at all.
Then can we recheck the blood pressure now?
Oh, I feel really weird.
Oh, and your tummy?
It's a lot worse.
Okay, monitoring is still fine, but you're not looking very well, Rachel. So I think we'll see what this blood pressure is.
Sophie, it's 162 over 104. So
162, 104. Okay, so we'll need to give some more nifedipine. And okay, right. Pull the emergency bell. Thank you. Good down, and then we'll get into left lateral. We've had an eclamptic fit. Jane, can you put this oxygen on for me? Can someone get the emergency box?
Take your face mask off for you now.
What's your name, sorry?
Kathy, could you get the eclampsia emergency box?
Yeah, sure.
And can you put out a 2222 call, obstetric emergency, room 1, central delivery suite?
Yeah.
And let me know when you've done that.
Okay.
Thank you.
Okay, so airway, that's fine, breathing, good. Can you,
I don't.
That's okay.
Do you want me to get IV access?
Yeah, so that would be great. We've got one cannula in. If we get a second cannula in, that'd be great.
Hi, Sophie. I bought the emergency box.
Great. Kathy's got the emergency box. Jane, would you be able to sort out the magnesium sulfate with Kathy? We need to give 4 grams IV in 16 mils of normal saline. I'll just prescribe it. Hi, Tim. Hi. We've had an eclamptic fit. This is Rachel. Her background is she's 39 weeks pregnant. She's a primate. Otherwise fit and well. Came in today with a headache, visual disturbance, epigastric pain. We haven't got a urine sample yet, but blood pressure was 165, 110 when she came in. We gave a 10 milligram nifedipine, and it didn't come down, and then she fitted for about 30 seconds at 11:31. It's self-terminating. So we're giving a loading dose of magnesium sulfate now. Neil's inserting a second line. And otherwise, CTG is normal and OBS are normal now.
So Rachel, I'm just a senior doctor. We're going to check on a few things and let's look after you. Can I have the eclampsia algorithm?
Yes.
Let's start with that, shall we? Great. So let's. Can I just quickly check a few things, everyone? Left lateral for Rachel. Yep. High flow oxygen.
Yes, that's on.
And we've got a second cannula, and we're doing some bloods now, Neil.
Yep. So just taking some bloods.
And Jane, we've got 4 grams IV magnesium sulfate.
Doing that now.
Great. And Kathy, you're doing the...
I'm writing down. She's documenting.
Documenting, that's great. 168 over 112, so still pretty hypertensive. So I don't think, Neil, we can rely on oral norepinephrine. So let's go for IV hydralazine. So if you could get 5 milligrams of IV hydralazine, and we go for the 15 minutes approach.
Yes, that's fine. I'll sort that out with Kathy.
That's great, thanks, Sophie.
Okay.
So Rachel, your blood pressure, we're just going to need a little more treatment. We've given you something to stop you having another fit. Your baby looks absolutely fine. You're going to be absolutely fine. I'm just going to make a plan with the whole team about where we're up to. Magnesium sulfate's in after eclampsia. We've got a plan for the hypertension. We need to pop a catheter in, Sophie, at some stage.
Yeah.
Neil, anything else you think we could do?
Should we restrict fluids as well?
Let's restrict
Yeah,
fluids,
so
that's definitely
on the
sensible.
severe preeclampsia algorithm, yeah, we restrict fluids to 1 ml per kilo per hour.
Yeah. So we're just going to get a few things ready, and let's make a decision about how we're going to have this baby in about 15 minutes.
Okay, so I'm going to stop sharing this, and then we will and share my other screen again. So this video was provided by Prompt, and that's available on the internet for anybody to have a look at it. So the key factors that we looked in the video and in general in managing eclampsia is, firstly, it's an obstetric emergency. Declaring it as an emergency, resuscitation, minimizing maternal and fetal hypoxia, treating and preventing seizures, controlling hypertension, and then establishing a birth management plan. So we need help, and we need it has to be a multidisciplinary meeting. So we need our midwives, our most experienced obstetricians are available, the anesthetist, maternity care assistant. If it is out of hours, then we need the consultant obstetrician and anesthetist. We need to note the time of Caesar and arrival of the staff. In terms of resuscitation, we said most Caesars are self-limiting. So only supportive treatment is required. So airway breathing circulation, left lateral position, as we saw in the video, high flow oxygen by face mask with a bag, and that reduces maternal hypoxia and fetal hypoxia. You insert 2 wide bore cannulas on both sides and take bloods at the same time. So you send bloods for your full blood count, group and save, your liver functions, your urea and electrolytes, and clotting. Treating and preventing seizures, magnesium sulfate is the drug of choice. We in the UK use IV, and I know in India it is IV or IM. So whatever you use, follow your protocols, but the loading dose we give IV 4 gram intravenous over 5 to 10 minutes. And then you give a maintenance dose of 1 gram per hour, maintained for 24 hours following the seizure or the birth, whichever is latter. And if there are recurrent seizures, then you give 2 to 4 gram given over 5 minutes. With magnesium sulfate, and in general, you look at the respiratory rate, urine output, because magnesium sulfate is excreted through kidneys. You look at their refluxes, blood pressure, and oxygen saturation. We know that magnesium sulfate is a central nervous system depressant. So you look for motor paralysis, absent reflexes, respiratory depression, cardiac arrhythmias, or cardiac arrest. And the antidote is 10 mils of 10% calcium gluconate IV over 10 minutes. That's easy, isn't it? You just learn it. Fluid management is very important. So strict input-output chart should be maintained. Your hourly urine output measurements. And you don't look at your hourly, you look at over 4 hours. So over 4 hours, the urine output should be more than 100 mils. If the oral intake is adequate, then you don't need IV replacement, and you don't need to preload them if they need epidural. So basically, you fluid restrict them to 80 mils per hour or 1 mil per kg per hour. But standard, if you take 80 mils, that's fine. Then controlling hypertension, our aim is to maintain blood pressure of about 135/85 or less. And the first line could be labetalol, either oral or IV. Or you've got other things like hydralazine or nifedipine. When you're giving nifedipine, remember that you give the oral, you don't give the slow release in terms of eclampsia or severe hypertension, and you don't give the sublingual, because the sublingual again drops the blood pressure very quickly. So you give them the oral tablets. This just demonstrates their onset of action. When can you repeat it? So you all can have a look at it in your leisure. then it is important that we plan for delivery once the mother is stable. So important is not to rush into delivery. That's where, you know, problems happen. It is important to stabilize the mother. And the choice is between either induction of labor or cesarean section, and that will have to be on an individualized basis. And it will also depend on the gestational age and the Bishop scoring. And then once, you know, all this has happened, then we have to think about high dependency unit or intensive care, depending on the condition of the mother. Management of labor, if they're laboring, continuous intrapartum fetal monitoring, epidural analgesia is encouraged, measure blood pressure every 15 minutes. It's safe to have the mother normal active second stage, unless, you know, there's high blood pressure, so she's symptomatic, or she's got severe headache or visual disturbances, then you can curtail the second stage by doing an instrumental delivery. Ergometrin and symptometrin is contraindicated. You can give syntocinon 10 units intravenous or intramuscular. And we talked about the fits being for, you know, mostly postnatal, so close monitoring of blood pressure over the next 72 hours. Very important to score them for venous thromboembolism and give them thromboprophylaxis. Breastfeeding with the medications that we've talked about is safe. Obviously, there's a risk of preeclampsia in the next pregnancy, which is about 25%, and that's reduced by giving low dose of aspirin, 75 to 150 milligram in the next pregnancy. So moving on to preeclampsia. So we know that the definition of preeclampsia is new hypertension more than 20 weeks of 140/90 plus significant proteinuria, urine analysis 1+ or PCR of more than 30. And severe preeclampsia is severe hypertension, which is blood pressure of 160/110 plus minus symptoms or plus minus biochemical or hematological impairment. And the key factors in reducing morbidity and mortality is firstly, identification, escalation, and then diagnosis. Once you've made the diagnosis, then monitoring blood pressure and then treating the hypertension. Then once you've sort of made the diagnosis of preeclampsia, monitoring and managing maternal and fetal well-being, management of preeclampsia itself, and then determining the optimal time of birth. And once you've determined that, then in establishing a birth management plan. So it's similar, and it's a bit of repetition from preeclampsia, but from eclampsia, but I just wanted to highlight some of the points. So early antenatal assessment and identification of risk factors. So if you find risk factors, then you can give them aspirin, and that will sort of prevent them from getting preeclampsia, hopefully. At each antenatal visit, measure blood pressure and urine. In my clinic, nobody goes out without having a urine dipstick, however long they need to wait, because it's so important. Antenatal discussions about making patient aware of signs and symptoms of preeclampsia. And you can offer placental growth factor based testing if you have suspicion of preeclampsia or suspected preeclampsia between 20 weeks to 35 weeks, where again, admission or management planning may be helped. Monitoring blood pressure and treating hypertension. So oral labetalol should be started if the blood pressure is over 140/90. Severe preeclampsia, you can start with oral or IV, oral nifedipine or IV hydralazine, similar to what we did in eclampsia. The aim is to lower the systolic blood pressure and keep it around 135/85. And as we talked about, multidisciplinary input. And in cases of severe hypertension or severe preeclampsia, we can consider about invasive testing, invasive monitoring. Again, if they have preeclampsia, depending on what sort of we need to admit, 4-hourly blood pressure measurements, full blood count, your urea and electrolyte and liver functions, 2 to 3 times a week or even daily, depending on severity, fetal welfare assessment, accurate fluid balance, obstetric daily review, and thromboprophylaxis. And I have covered most of this in eclampsia as well. So determining the optimal birth for preeclamptics, 35, if they are 37 weeks, we initiate birth within 24 to 48 hours, because otherwise they'll have long-term complications later on in life, and also implications on the baby and the mother. Before 37 weeks, it will depend on maternal and fetal indications. And this is just some of the reasons why you would want to deliver before 37 weeks. And if you're delivering before 34 weeks, then think about MagSelf and steroids, because for both fetal maturity and neuroprotection. And then once you have made a decision for delivery, then you establish a management plan. So vaginal birth can be considered, cervical ripening is recommended, antihypertensives to maintain blood pressure, and then continuous monitoring. So in summary, important things that we've covered is controlling the blood pressure, preventing the seizures by giving them MagSelf, fluid restrict them, keep them dry, and plan of birth, because delivery is the cure for preeclampsia. Thank you very much. And I'm going to stop sharing now.
Dr. Deha, are you there?
Yes.
Neha Saraf, are you there?
Yes,
Okay.
yes, ma'am. Yes, ma'am.
Yes.
I was through the lovely talk. It was a very lovely talk, Dr. Nutan, ma'am. And especially the videos were very interesting. I enjoyed the talk thoroughly, and I'm very sure all the audience must have gained many practical points through the talk. Thank you so much.
Wonderful lecture, Dr. Nutan. You have elaborated such a simple language, a most complicated topic, nightmare for all of us. Especially the obstetric drill part was very nice. So we can imagine how we should deal with the patient as soon as we get the admission of preeclampsia or eclampsia. Wonderful slides, ma'am.
Thank you.
Thank you very much. Over to Dr. Jyoti. Any question, audience? Any audience want to ask question to Dr.
Malika, we will take that in panel discussion. Now we will go to the second talk.
Okay.
And I think second talk is by Dr. Deepali on impacted fetal head. Am I right, Nutan? Nutan, you are muted. Nutan, you are muted.
Yeah, that's fine. We can go in any order. That's fine.
Yeah.
Please ready.
So, Deepali, I invite, yeah. Jyoti, have you logged out? So I invite Deepali, and the chairpersons for the same are Dr. Shobna Mohandas and Dr. Vidya Thobi. We all know Dr. Shobna Mohandas is currently the National President of Indian Menopause Society, and Dr. Vidya Thobi has just finished her tenure as the chairperson of Food and Drug Medical Surgical Equipment Committee of FOXI. So I invite both the chairpersons to take forward and introduce the speaker, Dr. Deepali Sinha.
Dr. Vidya, would you be introducing or?
I
will introduce. Thank you, and thank you, Dr. Lakshmi. I think I'm audible to everyone.
Yeah. You are audible.
This is very
thank you,
interesting
Lakshmi,
session.
for calling me also.
Yes. Both of us, we thank Dr. Lakshmi for inviting us. Such an interactive sessions you are arranging. And this is again an interesting session, that management of impacted fetal head at cesarean section by Dr. Deepali Sinha, who is a consultant obstetrician and urogynecologist at Newham University Hospital, Barts Health NHS Trust. May I have a CV of hers?
She will have to. Deepali, would you like to stop your screen share so that I can show your CV slide?
Okay.
Yeah. Just thank you.
Hello, Deepali.
Yeah, because I really want audience to know you formally. Yeah.
Yes.
This is her CV slide with them. Yes.
Yes. The fetal extraction is very, very difficult when we come across deeply impacted fetal head whenever we do cesarean deliveries. So there are various methods by which we do, and we are familiar with, which requires really an expertise and expert obstetrician to deal with such an impacted fetal head when we come across. So why we are worried is because of there is always an increased maternal and neonatal morbidity and mortality. So mortality, of course, later on, and above all, I just want her to, Dr. Deepali, to just comment on floating fetal head as well. Whenever we talk of difficult cesarean extraction, we talk of both deeply impacted fetal head as well as floating fetal head.
Vidya, can you introduce her formally? Can you see her?
No, I am not able to see her. So in between, I was talking about that.
Okay, you are not able to see my screen share?
No, I can see, but the words means it is very small. No?
Ma'am, can you please make it full screen, Lakshmi ma'am?
Yeah, it is already full screen, dear.
No.
Can you share from Yogendra? Can you share from your side?
I can share, ma'am.
Yeah, I will stop. Yogendra is sharing. Yeah, Yogendra will.
Ma'am, I have joined. Can I share now?
Yeah, Jyoti, please. I was.
Jyoti, please, can you share about share the CV of Dr. Deepali's? Yeah.
Hello.
Jyoti, please share the.
Hello.
Could you try again?
Jyoti, you can introduce
Hello?
Dr. Shobhana and Dr. Vidya also. Yeah, please.
Go ahead.
No, you have already introduced us. That's enough.
Yeah, that is enough for us. Yeah.
Hello.
Yeah, Jyoti.
Yeah, ma'am.
Yeah. It's there. It's there. It's my pleasure to introduce audience Dr. Deepali Sinha. She's a consultant obstetrician and gynecologist with a special interest in urogynecology and laparoscopic gynecological surgery at Newham University Hospital Barts Health NHS Trust. And she has also been an NHS consultant since 2008 and currently RCOG tutor at the hospital, being responsible for the coordination of obstetrics and gynecology, specialty training and education program at the trust. She teaches undergraduate students that attend the hospital and an examiner at undergraduate and postgraduate MRCOG examination. She is the course director for combined online and practical perineal suturing course and practical gynecology laparoscopic training courses. Newham University Hospital is a very busy obstetric unit with a delivery rate of more than 6,500 per year. The unit has 20 consultants in obstetrics and gynecology and provides a care for high-risk pregnancies and complicated deliveries. So we would like to hear from expert Dr. Deepali Sinha about the management of deeply impacted head at cesarean section. Over to you, Madam Dr. Deepali.
Hi, thank you for your kind introduction. As you know, I'm one of the consultants working here at London, but I have graduated from India and basically, from not very posh state. I've graduated from Bihar.
Oh.
Fine. So I'm just going to continue on this obstetric skill session. So we're going to discuss a very important topic on the management of impacted fetal head at cesarean section. So what is it? It is naturally a complication occurring at cesarean section in advanced labor. At present, unfortunately, there is no consensus definition. Impaction of the fetal head refers to the situation in which the fetal head is lodged deep within the maternal pelvis, and it is very difficult to deliver it by usual maneuvers during cesarean section. Naturally, molding of the fetal head within the pelvis contributes to a lack of adequate space for the surgeon to insert a hand to try to dislodge the fetal head. Usually it is encountered at full dilatation. However, in a study which was conducted at NH North Bristol Trust in UK, has shown that more than 50% of the cases presented are just before full dilatation of cesarean as well. Naturally, it is associated with technically difficult births and lead to severe complications. So the working definition of impacted fetal head is very similar to the definition of shoulder dystocia, where additional techniques or tocolytics are used to disimpact the fetal head once standard delivery maneuvers have failed. I just wanted to say that I have taken a few slides from a prompt teaching material because they have done great work and I think we should all use that. Why do you want to discuss it? In UK, definitely there is a lot of press coverage, a lot of concerns about the safe delivery. It has become a massive issue, and press, they are mostly covering due to injured babies, particularly fracture skulls, and a number of other health issues when babies are delivered, and they are not as good in health condition as we expect them to be. And this, they are emphasizing on the improper management of impacted fetal head during cesarean delivery. So coming to the incidence of impacted fetal head, at the present, there is a very few national or international data available related to the incidence of this problem. NHS Resolution Early Notification System, which provide insurance for the birth in UK, they identified that impacted fetal head contributes to 9% of their most costly cases. Canadian has just published a committee opinion where they have found that impacted fetal head has been estimated at 1.5% of all cesarean delivery. Going back on this National Bristol Trust, which was done by Tim, and they have done a great work. They looked at about 900 consecutive emergency cesarean delivery in the trust in a year. And they found that impacted fetal head complicates 11% of all emergency cesarean section. It also complicates 32% of cesarean section at full dilatation, which is just over the 50% of impacted fetal head in prior to full dilatation of cesarean section. Complications of impacted fetal head, definitely when we are delivering, doing cesarean in a fully dilated uterus, lower segment is very thin. And by adding all these maneuvers, they are very liable to tear, and tear can extend deep into the cervix or into the vagina, leading to injury of surrounding structure, especially the urinary tract, because these patients, they bleed too much, so they are at a risk of excessive blood loss. And the presence of so much blood makes it very difficult to see where we are putting the suture, and that puts the ureter or bladder more at a risk of injury. Naturally, these prolonged labor injuries, PPH, can delay these patients' recovery. They are more prone to develop sepsis, and they may end up with hysterectomy if we are not able to secure bleeding appropriately. Regarding baby, naturally, they do suffer different types of fractures. The common one is definitely a skull fracture and nerve injury. However, there is a hypoxic brain damage. Recently, encephalopathy has been commented, which is very peculiar to impacted fetal head. Usually, there has been a cystic changes noted in white and gray matter, which could be due to the global pressure applied on the baby's head, which causes a reversal of the CSF in baby's head, and that gives the cystic changes, which can lead to long-term complications, including death. About the risk factors for impacted fetal health, we all know that if in first pregnancy and delivery, people are always prolonged, that can lead to long labor and increases the risk of all instrumental deliveries and failed instrumentation, and leading to impacted fetal head and delayed complication related to that. Baby being microsomic again increases those risks. And intrapartum factor, all these, which, where the labor is prolonged, there are features of obstructed labor, malposition of babies, especially in OT and OP position. Syntocinon augmentation, again, causes more impaction of fetal head, which increases the risk of development of impacted fetal head. Regarding operators, it is very much dependent on the skills. And in UK, junior doctors are more likely to report than consultants. It was unheard by the senior consultants. I'm not very sure, but maybe very likely it wasn't a recognized complication or issue by them. But now in UK, it has been recognized as a serious obstetric emergency. And we have included it in our training, especially in the simulation training, so that we can have a better understanding how to manage these situations so that outcome will be improved. So coming on to the trainees' view, in UK, a national survey was done, which was done again by the Bristol team, where they have sent the questionnaire and asked different grades of obstetric consultants and also trainees about their view, what this problem is, how much they are aware of, and what many methods they can use to safely deliver the babies. So it looked at basically the current practice and training for impacted fetal head at cesarean section. There was a universal comment about paucity of training. At the moment, current practice is that about 71% of operator, they lower the table to facilitate the delivery. And about 41%, they change hand. I know I've been taught as well, because I'm right-handed, change it to left hand, and that may allows it easy delivery and reduces the risk of injury to the lower uterine segment. Coming to the training aspect related to impacted fetal head, just over 1/3, they have some sort of simulation training, and 63% of them, they were trained to push-up method, and only 42% they have some training about pull methods. And looking at the Patvardhan, only less than 10% of the trainees or consultant group, they felt they have some sort of training related to Patvardhan maneuver, and only 3% of them, they feel confident in using it. So it is a very heterogeneous condition, and there are many risk factors, but no actual accurate predictor. Therefore, it becomes very difficult to predict when it's going to happen. Therefore, it is more important for obstetrician to be vigilant for the possibility of impacted fetal head in all emergency cesarean section. We should start with easy maneuver, which we are all familiar with. So the common way we all deliver is we put our dominant hand inside the uterus, we flex the head and then lift the head prior to delivering it out through the incision. Naturally, if that maneuver is not successfully delivering the baby, we have to go on the other maneuvers, which include vaginal push-up by assistant, which is very well recognized practice in the UK. Then reverse breech extraction, which is also a pull method, extending the incision using T or J incision, or switching to other strategies like Patvardhan method, fetal philo, and tocolysis. I like this picture because it just gives you an idea how difficult situation we are in. It's literally like a ball or which is really tightly fit in a vase. And we are not able to reach it by putting our hand. We all know it's much easier if we can give a push, then ball will dislodge. So I'm just going to go through a scenario. Mrs. K, she is 37 years of age. She is in her first pregnancy. Her BMI is slightly on the higher side of 40. Her labor was induced, and the labor was augmented with the help of syntocinon. And we know it's a prolonged labor. On examination, finally, she was fully dilated. Head was found to be in OP position at a spine or +1 with ++ of caput and molding. She was taken to theater, as we do in UK, with all where we anticipate delivery. We do take them for trial of instrumental delivery ± cesarean section. Attempt was made, but it was unfortunately unsuccessful. So what are the things going through your mind? I'm just touching upon this disimpaction study, which is results are still not out. It is a simulation study conducted at 3 units in UK, where they have invited different grades of obstetricians and also midwives and other team members. And then they were allowed to do disimpaction on simulation. And after that, they were videoed, and after that, they were questioned about difficulties and issues they have encountered and what they can suggest to improve the teaching and training for this problem. The one thing which was very highlighted is about communication. As Nutan already mentioned, in all obstetric emergency, communication is a very important aspect, and we can never underestimate the importance of that. So whenever we are going to encounter the situation where we have failed, baby is in OP, then we have to communicate with our team. Different team members need to be aware that it is an emergency situation. We need to declare that so that people are prepared for the implications. If delivery is conducted by a junior obstetrician like ST4 or 5, definitely they need to escalate and get the senior trainees or consultant. And also it's very important to give very precise and a specific instruction on how to perform maneuvers to disimpact these impacted fetal heads. So the further advice which was required by obstetrician is definitely once you have failed the instrumental, now you know that you are going to do a cesarean, try to disimpact and push the fetal head vaginally prior to starting the cesarean section. You have already communicated with the team, so they are aware. Once you have started doing section, we all know when we give the uterine incision, uterus contracts. So when uterus contracts, it will become very difficult to deliver these baby. So it is very important just to take a minute, because uterus will relax, and then it will be easier to put your hand through the uterus and try to deliver it. There should be slow, deliberate, and gentle movements because uterus is friable, and we will do more damage if we are in a haste. And we will also, if we are panicking, we will upset whole theater environment and everyone will start panicking. Then we need to, they do suggest that you enter your hand laterally rather than going in the midline, because there is more space laterally, and that allows your head to go down, and then you can flex the head, elevate, and deliver. Semi-lithotomy position has got advantage because it allows assistant to give vaginal push. And there is a place of tocolytics, we should be using it. And some people, as I mentioned already, they lower the table. Naturally, you have done all and it has failed, then we need to consider alternative maneuvers. So we have to think about the other team members which are around us. Midwives, they play a very important role, and they are the one who will be doing the disimpaction during cesarean section. So do liaise with them. They will also help us to call neonatal team if they are not already present, and also to subscribe so that documentation will be accurate, and so that if anything goes not as outcome is bad, then definitely we can reflect upon the timing and everything. Neonatal team, they are very important. If there is a junior present, do call your senior, because delay in delivery will impact the outcome. Anesthetist, they control the whole situation, so very important to speak to them, make them aware that we will. This is the situation. We may need to change bed position, may need to lower or other things. They will anticipate giving the tocolytics, will be prepared to tackle with PPH and need for other uterotonics. Theater team, again, very important role. They will help us with the scribing, help us with getting all the different equipments required to handle this emergency situation. So coming to the vaginal disimpaction and push technique, This is naturally a method very commonly used in UK. The recommendation is to put a whole hand rather than 2 fingers, which we normally use when we are doing vaginal examination, because naturally 2 fingers increases the risk of a skull fracture. It is very important when we are asking the person to give us the head flexion to describe them where the head is actually positioned and which direction they need to flex so that it improves the delivery. Vaginal access, we can put a hand by Pringle hand technique, or like putting a bangle. We all very much familiar how to put a bangle. Or we can cup the hand to cradle the fetal head and use the flattened surface of finger to flex and then elevate the head. Coming to the reverse breech extraction, this is possible in when it's an OP position. You introduce your hand inside the uterine cavity and grab the foot and deliver the leg, one at a time, and then deliver the body and head. So that's the way I think majority of us, we don't succeed by push method, we deliver them with this reverse breech method. Coming to the Patwardhan method, it was first described by Dr. Patwardhan working in, Bombay, in 1957. It definitely not very common practice in UK, and unfortunately I'm not myself very familiar and I have never done this myself, so I don't think I'm in a very right position to describe this method. But definitely it involves initial delivery of anterior shoulder, mainly when baby is in POA position, because OA position you have got back in front. So it includes anterior shoulder delivery, followed by the posterior shoulder, then legs, and finally the head. Naturally, when we have delivered both shoulders, assistant applies fundal pressure, which promotes the flexion of the body. And at that time, operator, they apply gentle traction to flex the body's abdomen and deliver the buttocks and leg. And finally, head is then delivered. There is a very nice video on YouTube, so I'm sure you can all watch that. And I'm sure you all must be practicing this much more than what we are doing here in UK. But this is definitely one of the very good technique which we can practice on simulation. Okay, coming to the fetal pillow. Fetal pillow is a very soft material which we put under the fetal head when we have failed instrumental delivery or when we are anticipating difficult delivery at full dilatation. Usually 180 ml of saline is used to fill this white soft thing, and it pushes fetal head. I'll come back to all the evidence supporting or not supporting these particular maneuvers later on. Naturally, particular to the fetal pillow, there has been a retrospective study done in UK where they have looked at 471 cesarean delivery at full dilatation with 170 cases use of fetal pillow with control of 21. And they did not find any statistical benefit to prevent maternal and fetal adverse outcome with the use of fetal pillow. Second thing is about the expense. Each fetal pillow cost about $250. So we do need to justify whether about the cost of use of fetal pillow versus the benefit in this current climate. So the evidence regarding the push and pull method, there has been a Cochrane review in 90s and systemic review and meta-analysis done in 2015. All these, they have looked at different observational studies and RCTs related to these issues, and both of them are in favor of pull techniques, as this reduces the risk of uterine incision extension. However, there is no significant difference found related to neonatal outcomes. And also, they did not find that tocolysis does any good or any benefit in this situation. However, I still use tocolysis if I need to deliver, because maybe it's just my practice, or maybe I feel comfortable. Overall evidence related to the management of impacted fetal head. At present, naturally, there is no consensus for safety and or most effective strategies for impacted fetal head. There is no standardized management guidelines. There has been a possible, evidence supporting possible reduction in maternal complications with pull-up compared to push-up techniques. And in the North Bristol trial study, definitely they found that there will be requirement of more than one technique to safely deliver these babies. And this again shows the parallel or similarity with the shoulder dystocia, which is also another obstetric emergency where we do routinely use more than one technique to safely deliver baby. At present, MIDAS study, they are looking at a UCOS study of second stage cesarean section. And we are all eagerly waiting for the result to come out so that this will give more light on how we can safely manage this difficult situation. Just a brief touch on medical legal issues. In UK, as you know, we do have a lot of medical legal issues and litigations. It constitutes only 5% of babies who come out as injured due to impacted fetal head. But when they come out, definitely it is associated with diverse range of infant brain injury, which include from a skull fracture to ischemic cephalopathy or any hypoxic changes. Severe brain injuries were as common in cesarean section prior to as at full dilatation. And we all know longer incision to delivery will decrease the good outcome. Therefore, especially we need to time and make sure we deliver these babies safely. However, the consultant presence or fetal pillow has not shown any beneficial effect. Single forceps blade has been criticized, which at the current practice not used in UK, and it is associated with more harm to baby and mother. So just to summarize, it is a relatively common condition than we initially thought, and we all know it is a heterogeneous group of problem, which can be very stressful. Definitely more research is needed, and we are awaiting the RCOG scientific impact paper to give us more insight about this problem. If impacted fetal head occurs, definitely we need to communicate appropriately. We need to involve senior support. You start with simple techniques which we are more familiar with, including flexion and elevation of fetal head, and then go to other maneuvers. Using an evidence-informed approach when we anticipate fetal head is really the way forward, and that will reduce both maternal and fetal complications and related to that short and long-term harm caused, and also associated with all these medical legal implications. Research into the value of simulation learning, regular labor ward assessment, and possible intervention will definitely help and improve the outcome. And we can never emphasize less on human factor. Naturally, as an operator, we get absorbed in the situation. And sometimes we don't realize what we are doing. And if we are not succeeding on timely manner, definitely the team members should intervene, and we need to get we should value others' opinion, because that will lead to the safe delivery. Thank you. I hope you find it useful.
Thank you, Dr. Dipali. You have, I have not so far heard about that breech thing. We all do the patwardhans when the head is post anterior. When the similar thing only, when the head is posterior, instead of taking the shoulder out, you take the breech out. That makes sense. And now
Yes.
you told me that you put the patients on dorsal position, semi-dorsal, so that you are ready for an impacted head. That's little difficult in our country. I don't know what happens in medical colleges, but we really do not always anticipate an impacted head, because they say that you can wait for 2 hours or 3 hours in full dilatation, almost 5 hours at 5 centimeters, 4 hours at 6 centimeters. And that long when you wait, maybe if you really complete the full course of 4 hours or 5 hours or 6 hours prescribed by WHO, the end of that time, probably you can expect impacted head and then put the patient in dorsal position. That way we should improve our practices according to what you're saying, that in UK you all are putting the patients in dorsal position in anticipated cases. Here we really don't do that, because even if you have a patient whose head is not coming out, we somehow feel that okay, when it comes there, it will come. Unless you have been waiting at station +2 for a long time. Waiting at +1 for a long time, we somehow feel that we won't be screwed up at the time of section, so we don't really wait with dorsal head. And torcolysis, you said you're giving torcolysis. I also feel that the studies that showed that torcolysis is not useful may be right, because you're actually only relaxing the uterus. The problem is in between the head and the pubic symphysis. Why should relaxing a uterus make a difference? So probably the studies are right, but then some things like you're habituated to doing some things and you can't change it.
True. Completely agree. Yeah. And I think it just allows your hand to go more. Or maybe I think it's just, as I said, the practice. We are all bound to do what we have been doing.
Yeah, that's there. Then push and pull up technique. Why don't we do both together? Why only one push? It's normal that somebody pushes from below, creates the vacuum, and the other person is pulling. Where is this push versus pull?
I don't think there has been any study on combining both together, but naturally when we have failed instrumental delivery, we all push the head, flex and push it up. So we already have done a push, and then
then somebody pulls it. So where is this push versus pull? Anyway, it's okay. That you have taken so much of effort to study a push versus pull. But I feel in a given patient, you would be automatically pushing and then breaking the vacuum from below with a push, and the operator from above would be pulling. So that's
for us, I think, Shobna, I do agree. And for us, Patwardhan method, we are so used to Patwardhan method.
Exactly.
That we never do this push and pull at all. So we are so used to this Patwardhan method, and it is very, very comfortable for us. Another thing I want to comment from Deepali is the incision over the uterus. We tend to take, whenever deeply impacted it is there, we tend to take incision more down. But when there a low segment is totally stretched, usually the incision goes down and down, and maybe you are incising really the vaginal wall. So many times there are extension, and the repair becomes many times very difficult.
And bladder injuries.
Yeah, bladder injuries are very common. So incision over the uterus, whenever you are delivering the deeply impacted head, should be little higher. What do you think so?
No, we all give very high incision just at where you lift the utrovesical fold. So it's literally at the top.
Yes. We usually this mistake happens, that when there is a deeply impacted head, we just separate, and many of the youngsters, they feel that we should take the incision very low. That should not be taken. That's what
not at all, because then you are bound to have, then it will extend. And because cervix and uterus has become one part, so it's very difficult to differentiate.
Where the uterus ends, where the cervix begins, where the vagina starts, where the bladder starts, everything is
we don't know, because there is so much, this one in prolonged labor, there is so much difficulty to decide.
So what Deepali is saying is that even you don't have to push down the bladder.
Yeah, we never
as soon as you open, you just open the bladder peritoneum. You don't even push the bladder down. Is that
And
what
what
Dr.
about the
Vidya?
instruments, single blade?
And you're keep on putting the hand on the side and then bringing it to the
laterally.
center. That's a very good tip that you've given. Yeah, now you tell about the instruments.
Instruments, I want to comment on the instruments. Single blade forceps, any modifications you are using there. We have in India, Dr. Venkatesh in Bangalore, he has done a modification of single bladed forceps, like this. So like that, any modification, any studies are available in your institution. How about it?
Not with modification, but they have criticized using single blade because that causes more trauma. They are clearly saying not to use it. But as I said, we don't have lots of evidence to support one or other maneuvers at the moment. And that's why I think more and more study, once this UK COS study, MIDAS study comes out, then we will have more information. So definitely more, there is need for more research to get, clearer impression of how to manage this situation safely.
Thank you. Thank you very much.
Thank you so much. Thank you, Dr. Vidya Thobi ma'am, Dr. Shobna ma'am, and a superb talk by Dr. Deepali. Shoulder dystocia, we've heard so many times. We do drill so many times. Impacted fetal head, we have ignored it and we've not taken it so seriously because, as Shobna ma'am says, when we do it, we expect that we'll be able to handle it.
Yes.
If we are
that is what very clearly proven in this national survey.
But I think your survey, which says 50% of impacted heads, I don't know if that much of is there or what? 50% impact?
No, not the 50%. Just over 50% happens
over
50% full dilatation of full dilatation cesareans. Maybe at 8 centimeter or something.
Even 10% is little high or what is it?
That is the quote. 11% is all emergency cesarean section. Yeah. That is the quoted figure, but it varies.
Every 10 cesareans, you should be having one impacted head in that
full dilatation, yes.
Is it that high? I don't know. Whoever is handling a lot of obstetrics will have to answer. I don't handle that much to say, but I feel 1 in 10 won't go. Maybe we are doing sections too often, unlike UK. We are not bound by, we are scared.
Yeah,
we don't have insurance cover and everything.
Rate is nearly 25%, and we do a lot of instrumental delivery, which is about 12-13%. So it's not that
we do go in for section much faster. In India, maybe that's why we don't have this 1 in 10% getting to impacted head. I don't think.
No, madam, in the periphery, we get such type of cases. The patients, they come in the obstructed labor. And I think every 10 or 11th patient is a obstructed labor. So a lot of patients.
No, 1 in 10 cesareans that you do in Bhagalpur are impacted heads.
No, not depend from center to center.
No, Bhagalpur is a rural area and she deals with a huge number of patients. So she is the best person to tell.
Yeah, we get the referred patients from periphery, and there are patients we get. I think every third or fourth day we get one obstructed labor. So
I'm not talking obstructed labor, Pratibha.
No, but
every 10 sections every 10 sections you have an impacted head.
Around, madam, it must be around 11.
That's okay. That's fine. So you are on same level as UK people.
Yeah, we have that type of patient.
Okay. Yeah. And you do it Patwardhan or push or pull what?
Patwardhan.
Everybody does Patwardhan.
I think we all are trained in Patwardhan from our PG days. So we all are very comfortable with Patwardhan technique.
Exactly.
And discussion we will continue during the panel discussion as well. So Jyoti, let us start with our third talk.
Dr. Deepali ma'am, can you stop sharing your screen so that we come over to our next?
Yes, stop.
Yeah, so thank you so much. Thank you. And I would now share my screen.
Thank you.
Yeah.
And we have our next set of chairpersons. We have Dr. Varsha Baste, a very well-known figure in India and abroad as well, because she is a chairperson of Indian Academic Exchange Committee of FOGSI, and she is director Baste Hospital, and she has a vast experience, And then we have our second chairperson, Dr. Bharti Maheshwari, who's Professor Head, Department of OBGYN and IVF, Muzaffarnagar Medical College, UP. She's also president of Meerut Society and she's secretary of UPCOG. She is FOXY MTP committee chairperson. And over to my chairpersons to please introduce our next speaker, Dr. Deepa Nair.
May I? Dr.
Yes,
Jyoti?
Yeah.
Thank you so much, Dr. Lakshmi and Dr. Jyoti and my co-chairperson, Dr. Bharti, for having me all of you here. This ongoing series is such a favorite of all India. The international updates we are getting of obstetric deals, it's unmatched. The excellence and the standard is really unmatched. And the chairpersons and the faculties and the selection of the topics is really, really wonderful, mind-blowing, and it's such an academic feast. Really thankful to you all for having me here. So let me introduce today's third speaker, Dr. Deepa Nair, and I'm also fond of Dr. Pundir, who is doing wonderful work in this field of communicating Indian and international platform together. She has come, Dr. Deepa Nair resides in UK, completed MS from Government Medical College, Kerala, Trivandrum, completed Indian MRCOG and further training from UK, diploma in medical education from Cardiff University, CCT with TSM's Advanced Labor Board practice and benign gynecology, followed by post-CCT fellowship and minimal invasive gynecology at University Hospital, Southampton. Currently working as a consultant in obstetric and gynec educational lead at Buckinghamshire Healthcare NHS Trust, UK, and keen interest is in medical education. Over to you, Dr. Deepa Nair, and you are going to talk on
maternal sepsis.
Maternal sepsis.
Yeah.
Maternal
Exactly.
sepsis.
Yeah. Good evening, everyone, from Chairperson Dr. Bharti Maheshwari, and it's really congratulations all organizing team from India, Dr. Lakshmi, Dr. Jyoti, Dr. Sushma Verma, and from UK. And these three important topics you have chosen, and in fact from all over India, from many medical colleges and societies from UP here, they are watching your session, and they are really very useful, especially impacted fetal head session as well as preeclampsia. And maternal sepsis, we all know that it is a very important cause of morbidity and mortality. And though in India and UK, the scenarios, infrastructures, working styles, they are little different, but we are very eager to hear Dr. Deepa Nair for his lecture on the maternal sepsis. Yes, Dr.
In fact,
Deepa.
we feel that there is no maternal sepsis in UK.
We see what she is going. We are really very eager to see.
Good evening, everybody, and thank you for the kind introduction. It's a pleasure to be presenting before you all again, and I do thank Ms. Mishra, Dr. Lakshmi Shrikande, and all the other organizers for giving me this opportunity. My topic for today is sepsis in pregnancy, and I'd like to start with why we chose this topic.
Dr. Deepa Nair is becoming favorite of Indian Foxians because of her talks. They are really reviewed very well. Thank you, Dr. Deepa Nair.
Thank you. I hope I meet your expectations. You're making me tense. I'd like to start with why we chose this topic, and what constantly intrigues me is the commonality of pathology over borders, across borders, globally, despite wide variations. So I choose to first look into the statistics from Embrace UK, which shows that sepsis contributes to 10% of all maternal deaths. In India, again, the percentage is fairly similar, about 11%. And if you look at it globally, again, sepsis contributes to about 8 to 10% of maternal mortality. And why does it become more important that we actually learn further about this? Sepsis is very much a preventable cause. Prompt recognition, referral, and action can improve outcome. We can save lives. To define sepsis, it is a life-threatening organ dysfunction caused by a dysregulated host response to infection. But what we need more is a guide for clinical diagnosis. Severe sepsis would usually be associated with 2 or more of the following: a temperature of greater than 38 degrees Celsius or less than 36 degrees Celsius, measured on 2 occasions, at least 4 hours apart; a heart rate of more than 100 beats per minute, again measured on 2 occasions; a respiratory rate of more than 20 per minute on 2 occasions again; and a white cell count of greater than 17 or less than 4 times 10 to the power 9 per liter, with more than 10% immature band forms, again on 2 occasions. The other important signs that we need to be aware of are hypotension, which is a systolic blood pressure of less than 90 millimeters of mercury; low oxygen saturations, less than 94% on room air; poor peripheral perfusion, denoted by a capillary refill of more than 2 seconds; cold, clammy skin; confusion, agitation; and rash or motile skin. We do give a lot of importance to lactate for the definition of sepsis in the general population. What we need to be aware of is things can be slightly different in a woman who has gone through labor. It can be raised transiently in labor, and at the end of the first stage, it can be as high as 2.6. After 1 hour of active pushing, it could be up to 5.6. It has a good negative predictive value in that if the lactate is normal, it is unlikely to be sepsis. It is hence important to take the clinical context into consideration. It needs to be repeated serially. If it is abnormal, that is, if it is more than 2, it needs to be done every hour. And it also helps to assess if our actions are working or not. Sepsis can occur due to a number of causes. It can be due to infection related to pregnancy, or one that is totally unrelated, like pneumonia or urinary tract infection. The most common infections that triggered maternal sepsis were caused by bacteria, such as E. coli. But those who are pregnant are also at a higher risk of complications from COVID-19, which also needs to be considered in the present climate. Group A streptococcus has also been recognized as an important cause for infection. The risk factors for maternal sepsis in pregnancy, as identified by the confidential inquiries into maternal deaths, include obesity, impaired glucose tolerance or diabetes, impaired immunity or any immunosuppressant medication, pre-existing anemia, vaginal discharge, a history of pelvic infection, a history of group B streptococcal infection, amniocentesis and other invasive procedures, cervical cerclage, prolonged rupture of membranes, group A streptococcal infection in close contacts and family members, and Black or other minority ethnic group origin. As with anything, prevention is always key. Sepsis prevention is the primary objective, and currently antenatal screening is offered nationally in the UK for asymptomatic bacteriuria. We know from evidence that has been existent for quite a while that antibiotic prophylaxis during cesarean section can significantly reduce the incidence of febrile morbidity, wound infection, endometritis, and other serious infection-related complications, and this has hence become routine practice. More recently, in 2019, we have data from the ANODE study, and this has shown that prophylactic antibiotics to prevent infection following assisted vaginal birth can cause a reduction in confirmed maternal infection by as much as 56%. The recommended prophylaxis is a single dose of co-amoxiclav administered IV within 3 hours after birth. I'd now like to move on to a case scenario on the basis of which I will discuss further management of a case of sepsis and the tools that we use in UK to help us guide management. Mariam is a 32-week primip who self-referred from home as not feeling well. She does not speak much English and is accompanied by her partner, who appears very concerned about her. On admission, her observations were done and the CTG showed baseline tachycardia. Her observations were abnormal. She was moved onto our labor ward in view of the CTG, and no investigations had been carried out as yet. To describe a little bit about her background, she is A positive, not known to be allergic to any drugs. She has no medical history of note. She is currently 32 weeks pregnant with an uncomplicated pregnancy so far. This, as I mentioned, is her first pregnancy, and her only surgical history of note is a LETS in 2016. On assessment, she looks pale, reports feeling tired and generally unwell. Her observations:
In progress.
a temperature of 37.9 degrees Celsius, blood pressure is 110/59, her respiratory rate is 21, and she's tachycardic with a pulse rate of 110. This is a tool that we use very commonly in the United Kingdom. It is called the Meo's chart, which is the modified early obstetric warning score chart. It is basically a graphical description of key observations, which include temperature, pulse rate, and blood pressure. The numerical values should be clearly recorded. Respiratory rate, pain score, and the degree of alertness of the patient described by the APPU score are also clearly documented. What you see on this side of the chart is what the response should be and what the frequency of monitoring should be. So the Meo score is 0. There is less cause for concern. And on the other hand, if it comes in the red, if it is more than 6, then treatment needs to be escalated and care needs to be escalated. Monitoring needs to be more frequent. Also, if I draw your attention to this part of the chart, if any one of the maternal high risk or red flag symptoms are present, we need to move on to the sepsis 6 pathway immediately. This again is another tool that we use in order to ensure that recognition is followed by prompt intervention. So as with anything, the first step is always to identify the problem. Is there a problem? The Meo's chart helps us to identify that the patient is unwell. And if so, we then try to use the maternal sepsis tool, which asks you, is the woman looking sick? Could this be an infection? Are there any red flag symptoms? And if so, start the sepsis 6 pathway straight away. Again, on the other side, it tells you how to manage the sepsis 6 and whether you have actually given each of the things that you need to give within the first hour, which is the golden hour for management. Going forwards, we get help. 3 in, 3 out. We need to give the woman IV fluids, antibiotics, and oxygen. And we need to take blood out for blood cultures, lactate, and also the urine needs to be taken to keep a strict eye on the urine output. This is a very interesting graph, which I took a while to understand, but it almost tells you exactly why the golden hour is so important. The graph shows that the outcome becomes poorer when the time from onset of hypotension to administration of treatment increases. And the physiology behind that is quite clear. If the tissue perfusion decreases, the antibiotic will not get to where it has to act, and that will straight away make your outcome worse. Fluid resuscitation hence becomes very, very key. Hypertension or an elevated serum lactate level of more than 2 millimole per liter should be treated with an IV fluid bolus. The UK Sepsis Trust recommends giving an initial challenge of about 500 mils of crystalloid over 15 minutes. This can be repeated to 30 mils per kilogram as required. If there is no improvement in the hypotension, or if the serum lactate continues to be high following the fluid bolus, the woman should be transferred to intensive care. And of course, with preeclampsia or with COVID-19, where there is reasonable suspicion and cause for respiratory compromise, we need to be very, very careful in managing fluids. And this would be a situation where the critical care unit needs to be involved, and the patient would possibly require intra-arterial monitoring to make sure that the fluid balance is accurate. In summary, be aware of sepsis and beware of sepsis. If sepsis is suspected in the community, urgent referral is indicated. The onset of life-threatening sepsis can be insidious with extremely rapid clinical deterioration. I hope I've been able to really labor the importance of the golden hour and the importance of hence instituting the 6 measures within the golden hour. Early liaison with the microbiology and intensive care team is critical, and not all fever is COVID-19. We should still consider all the other causes that we had before 2019 as causes for sepsis. These are my references, and thank you all for your patient listening.
Thank you, Dr. Deepa. Very nice and comprehensive lecture. And in fact, we all know that early identification and high index of suspicion for the cases for sepsis, and then timely treatment. Of course, it is a key factor for prevention as well as for preventing the morbidity and mortality due to sepsis, because it is the preventable cause of maternal morbidity and mortality. And in India, we are in last few years, we have improved a lot, and very lots of infection prevention training programs, and are in the rural areas, our peripheral health workers, their trainings are going on for infection prevention management, and very small things like judicious PV examination, and very small things that are having a very important role for infection prevention. Thank you very much for nice lecture.
Deepa, what I like is the systematic approach of the team, and the documentation, 3 in and 3 out, and everything is done systematically. And documentation is so precise, so nobody can miss the diagnosis, and also the prevention part you have highlighted, that is also very, very important. Thank you for lucid, very elaborate and well researched, well studied presentation. Thank you. Nice. Always like to watch you and hear your presentation also. Thank you.
Thank you.
Thank you so much. Thank you, Dr. Chairpersons, Dr. Varsha Baste, Dr. Bharti, and wonderful, wonderful talk, Dr. Deepa, and we'll be discussing more during the panel discussion.
Yeah.
So coming on to the last bit, but the most important, most interesting bit now that we have, the panel discussion on the 3 topics that we've discussed: the maternal, the sepsis, the infected fetal head, and the preeclampsia. And for that, we have our moderators. We have Dr. Girija, Dr. Girija Bahag.
Jyoti, you can mention 1 line each about all the 3 moderators and 6 panelists, so that in continuity we can have all the 3 case discussion.
Right, ma'am.
Yeah.
So we have Dr. Girija Bahag, who's the Professor, Department OB/GYN, Bharatiya Vidyapeeth Medical College, Pune. Then we have Dr. Savita Tyagi, who's Director, Senior Consultant, Ishwar Nursing Home, and who's Chairperson, IMS Rural Committee. And our third moderator is Dr. Bhavna Khera, who is a consultant OBGYN, and she is member of the Safe Mother Committee, Fox. And we have the three experts. We have Dr. Nutan Mishra, Dr. Deepa Nair, and Dr. Deepali Sinha, who would be giving expert comments during the panel. And the panelists that we have Dr. Apurv Datta. I hope Dr. Datta has finished his surgery on rupture uterus and is joined.
Yes, ma'am. I have already joined. Yeah. Thank you.
I hope you could save the uterus, I suppose.
No, unfortunately not, ma'am. Unfortunately not.
Oh my God.
No, it was a large lateral tear.
Oh, okay.
So I had to.
Yeah, but save the uterus is the theme that we all have to
Save the mother.
Save the
Yeah,
mother.
first save the mother. That is the thing.
Yes. So Dr. Apurv is a national coordinator for FOXY CME workshops for safe abortion and contraceptive cafe. And he is a consultant at Shri Durga Clinic at Dhanbad. Next, we have Dr. Shikha Seth, who's professor, head of Department OBGYN, AIMS, Gorakhpur, UP. And then we have our next panelist, Dr. Supriya Arwari, who's infertility specialist trained from Seth Medical College, Pune, and she's practicing at Bhiwandi for the last 20 years. And she is West Zone Coordinator, FOXY Adolescent Health Committee. Next, we have Dr. Sachin Lokhande, who is Director, Mahavir Maternity Surgical Hospital, Navi Mumbai, who's also ex-lecturer, CMC Law. Welcome, Dr. Sachin. And we have Dr. Pratibha Singh, who's Director, Healing Touch Multi-Speciality and Hospital and IVF Unit, Bhagalpur, and is also the National Coordinator for IAEC FOXY 21-22. She is also chairperson-elect for this for 23-25 and is president of Bhagalpur Menopause Society. And then last but not the least, we have Dr. Kanchan Sharma, who is director of Akash IVF Center, Kanpur, and she's the secretary of the Kanpur OBGY Society and president IHRF Kanpur. So over to my moderators. So we would be having 3 moderators and two panelists each for each topic. So I think how do we start with preeclampsia? Dr. Girija?
Yeah, Girija, I can see she is here. Yeah, Girija, please unmute yourself. Yeah.
Hello, everybody. I just wanted Dr. Lakshmi to tell us how much time do we have, because we are already at 6 o'clock.
Yeah, 15 minutes. I think 15 minutes are okay for one case discussion.
Yeah, so we will only take 1 or 2 cases, and we will just keep a time of 10 to 15 minutes for us.
Yes, please.
And I know with my expert panelists as Dr. Apurva and Dr. Shikha Madam, we should be able to deal with it. Thank you so much for this wonderful opportunity. And let's look at quickly the case number 1. I think this is the one which we'll discuss only. We won't go to the rest of the cases, is what I'm foreseeing. But she is a gravida 2 at 32 weeks period of gestation, came to the antenatal OPD with a BP of 150/100, 2+ proteinuria, uterus 32 weeks. And she gives history of BP records in the range of 140 to 150/90. So Dr. Apurva, what would be your plan of management for this patient?
Ma'am, first of all, at the outset, thank you so much, Lakshmi ma'am and Girija ma'am, for the opportunity. So coming to this particular patient, since the patient is not at term and it is only the mild to moderate of the preeclampsia, so the first mode of what I will suggest is the conservative management till at least to the when it crosses the period of viability. Now, when I'm talking about the conservative management, we have a 3. Our aim. First, to use the antihypertensive to reduce the blood pressure. Second, to have the fetal lung maturity. And third, to plan the delivery, when to deliver, when to deliver, and for looking after the optimal, maturity of the baby as well as the mother. So this is our plan of action. What we have to do, we have to weekly ANC for this patient. You have to do the blood pressure monitoring. Now, nowadays, even our patients, what they are doing, they are the self, blood pressure at their home. So what they are using are actually not the mercury sphygmometer. So we have to advise them to calibrate it before they are using. This is very important. Now, whenever the patient come weekly, when we ask the patient to come, we have to check for the blood pressure. We have to check for the urine dipstick, and these are the things we have to
Yeah, Apurva,
assure
let
the
us
fetal
look at
heart rate.
Apurva, sorry to
Yeah,
cut you
ma'am.
short, but this is a patient whose blood pressure is 150/100 with a 2+ urine protein already. So what is the
Yeah, ma'am.
diagnosis? She's
Ma'am,
pre-eclampsia.
definitely
So
it's
now
a
he's
case of
pre-eclampsia. What do we do
yeah.
next?
Ma'am, lowering the blood pressure. We have to give
Okay.
antihypertensive first.
Anything else? One is going to give. Yes, Dr. Shikha, would you want to say?
Yes, ma'am. Because this is probably if the first time we are getting this patient with high blood pressure, 150/100. So, and along with proteinuria means there is some other factor which is associated with some organ dysfunction. So she belongs to pre-eclampsia, and I feel at this first instance she should be admitted for examination of the complete all systems, so that we can find out what are the systems which are non-functioning. So all complete profile related with pre-eclampsia, including LFT, KFT, CBC, electrolytes, ophthalmic examination, fundus examination, all those things has to be done completely, so that we can find out what are the areas where we have to intervene. We have to follow up.
Because Apurva mentioned that she is 32 weeks, you would like to wait for a while, but then waiting for a while will be determined correctly, as Shikha said, by doing the lab test, because we have to look for laboratory underlying pathologies. She may be having, because proteinuria means it is pre-eclampsia. This and current guidelines say that 150/100 with 2+ protein, it's always better to hospitalize the patient and assess her and then take her on. Would you want to give her antenatal steroids at this point in time, Dr. Apurva? Antenatal steroids?
Yes, ma'am, because he is less than 34 weeks. So we can.
Delivery may be imminent. We may have to take her for delivery. So it's better to give her an ANS. What about magnesium sulfate? Would you want to give magnesium
Ma'am, it is really preferred if it is the below 32 weeks of gestation, because it acted in neuroprotection. But see, already 32 weeks and more. So at this age, it doesn't have any role.
Yes, I also absolutely agree with Dr. Apurva. Magnesium sulfate probably is not required because she is presently not at a severe preeclampsia kind of a stage.
I'm asking Dr. Shikha for neuroprotection.
Ma'am, I am talking about magnesium sulfate for neuroprotection of the baby.
It's not only for prevention, but also for neuroprotection. Dr. Shikha, what would be your opinion on this?
For neuroprotection also, if we end up going into delivering the patient, then only I feel as such, if this case particularly is there. If we feel that we have to deliver in next 1 or 2 days, then only
I know there is a lot of controversy, and every time this gets discussed when the delivery is imminent, when there are any signs. But I will just tell you what I am practicing. Both of you are right in what you're saying, because that's the evidence that you say. But we give 24 hours magnesium sulfate in these patients also, because we know sometimes there can be convulsions, and we can give them an extended advantage of neuroprotection. So this, what you're saying is also right. And this is what we are also practicing. And both the things only maybe time will tell us how we can go about. So we have done the maternal surveillance. As Dr. Shikha said, we'll be looking at all the tests. What are the fetal surveillance parameters that Apurva you would want to do?
Ma'am, first of all, ultrasound, definitely for exactly gestation age, what is the weight, amniotic fluid, and definitely Doppler, whether the blood supply is adequate or not. And secondly, we have to do a biophysical profile twice a week and non-stress test twice a week. Yeah, definitely.
Yeah, if we
These
decide to temporize her, that is, if we decide to deliver her, then we wouldn't do. So antihypertensive medicines in pregnancy, Dr. Shikha, if you can just tell us, like what would be your first choice of giving a medicine to her?
Because in this particular case, we have a category of preeclampsia, not that severe variety. So we will start with an oral preparations, preferably with the labetalol as a first choice, or if it is not available, then nifedipine. These two are we will prefer more, but earlier we used to use methyl-dopa, but it's not that good as such. For severe particular cases, if the patient goes into an severe hypertension category, then we can go for IV labetalol or hytlazine, if whatever we feel so. I think labetalol, starting with labetalol BD twice daily is really good enough at this particular stage, and then we can add on increase the dose, and if it is not controlled, then we can add on the second category, that is the calcium channel.
So I agree to you. We will be starting her on medium dose of labetalol only if she is an asthmatic or has bradycardia. We would choose to give her nifedipine, or as you said, depending on how she responds. And methyl-dopa, unfortunately, is not available. But I must also bring to the notice of all our panelists that there are many friends and colleagues across the country who are also using Nicardia. So they are using nicardipine instead of nifedipine very, very successfully. Unfortunately, we need to publish all these experiences so that we can put it in our guidelines. Now, what is the target blood pressure that you would want to achieve, Dr. Apurva? Yeah. Okay, Shikha, you can answer that. Yes. Target blood pressure. I'm sorry, you are not audible. If you can increase your volume or come closer to your machine.
Yeah, I feel in the case, this particular case, we should try to maintain systolic blood pressure between 150 to 140, and that's
I'm sorry, at least I did not hear you. Maybe the rest of the people have heard you. I'm not aware. But let's reiterate what you're saying. Yes, and I can understand that you are saying that we must achieve a balance where there will be not sudden too much of hypertension. At the same time, the fetal perfusion will be properly, the placental perfusion will be properly maintained. And 140/90 would be an ideal blood pressure marking. And there has been a study which has shown, the CHIP study, which has shown that very tight control, in fact, helps in protecting the mothers, and it consequently therefore helps the babies and doesn't cause much of growth restriction. So what are the indications where you would now decide to deliver this patient? So who wants to take this answer? Apurva?
Yeah, ma'am. The indication when any complications develop along with the along with the preeclampsia.
Just enumerate them. Yeah. What are those? Yeah, enumerate them quickly.
Ma'am, we maybe the impending, eclampsia may be there. There we have the signs of, the aberrations maybe, or fetal, bradycardia is there. Fetal heartbeat is, going down. Or we have like loss of vision, or some any extreme bilateral edema is there, or there may be have developed the pulmonary edema. These are the fetal complications for which we have to terminate the pregnancy.
Absolutely. So eclampsia and HELLP would mandate a termination definitely, and HELLP can be diagnosed only by doing laboratory, as you correctly said. Any proteinuric hypertension, you are not going to temporize more than 37 weeks of gestation. And if it is severe hypertension, you must consider delivery by 34 weeks of gestation, because beyond that, it doesn't give any kind of an advantage. So if at all you have any expectant window in our patient at right now under discussion is between 32 to 34 weeks, we will take a call and decide. And after 34 weeks, there is no real advantage if it's a complicated severe preeclampsia and concluding her. So Dr. Shikha, would you want to talk about the termination indications of pregnancy, fetal indications?
Yes, fetal indication of termination is like whenever we come across a case, because most of the time preeclampsia is associated with oligohydramnios and the fetal growth restriction. So we have to follow up within sonography and Doppler parameters every 2 to 3 weekly, depending upon the severity of the preeclampsia. So if there is any time we come across a fetal distress, then we have to terminate the pregnancy. And if we have a pregnancy which is associated with fetal growth restriction, then we have to follow up that particular case with the Doppler is umbilical artery parameters. If we are finding reverse end-diastolic flow in the case of umbilical artery, or in that particular cases, we have to terminate pregnancy. So reverse end-diastolic flow or an absent end-diastolic flow around 32 to 34 weeks age, that is an indication for termination of planning for the termination of pregnancy.
Absolutely. So we have to look at the maternal conditions and the fetal conditions. And quickly, what are the recommendations for screening for this disease? Anybody can talk about it?
Ma'am, every patient, when the patient come to our OPD, we have to look after for the blood pressure. And we have, it is the universal screening as we are doing in the gestation diabetes. We have to give in every visit when the patient come with us, we have to look after the blood pressure, we have to look after the edema if developed, and we have to look after the protein urea. And what we in OPDR, it is the urine dip stick is freely available. We have to take with that, and every time the patient come with us, we have to do this type of investigations.
So at least taking the blood pressure correctly and looking at the history correctly would help, because there are many risk factors which have been identified to cause preeclampsia. Even if we are able to temporize those, and that is what we have mentioned in the gestosis score, which talks about, and so that you can implement all the preventive strategies such as aspirin, weight gain, diet, and so many other things. And we must go beyond ourselves to go and manage and try to prevent preeclampsia. I think our time is over. Do we have the permission of discussing the next case? Or should we wind up? Lakshmi, can you tell us?
Ma'am, if shortly in 5 minutes, if you can finish the second case.
So we'll have this case number B, where his 27-year-old primey at 37 weeks period of gestation was brought to casualty with history of 3 episodes of generalized abnormal movements with altered consciousness 15 minutes ago. And she was reported to be drowsy with a blood pressure of 170 by 120, albumin was 3+, and it was a term uterus relaxed cephalic presentation with a fetal cardiac activity of 140 beats per minute. So what is the diagnosis? Shikha?
Yes, ma'am, this is a classic case of
Shikha is not audible to me. I don't know, to everybody.
Ma'am, the clear-cut diagnosis is definitely the eclampsia.
Yeah. So this is eclampsia, and there can be sometimes other things. And if you want to be specific, you will say antepartum eclampsia, because she is not in labor yet. And maybe you must keep a few differentials in mind, of course, like if it's a diabetic patient, obese patient, cerebral, but for all purposes, any seizures presenting in a woman during pregnancy is taken as eclampsia and treated accordingly. And here we have a lot of confounding evidence in the form of 170, 120 BP and 3+ proteinuria. So how will you manage this patient of antepartum eclampsia? So what is the
ma'am, when we're talking about the treatment, we have to give the supportive treatment to the mother, the supportive treatment in the form of anti-epileptic first, and the definitive treatment is the termination of the pregnancy. So when we're talking about the epileptic, definitely magnesium sulfate, picardism. In the initial, we are discussed so much about that, how to give, what are the side effects. We have to look after urine output. We have to look after the plantar reflex, and we have to look after the respiratory rate and everything. Then we are giving the antihypertensive to reduce the blood pressure, and that is, yes, is unconscious or subconscious. So we have a very good enough, like labetalol IV is present. In initial days, even in my residency, I have seen that via the nasogastric tube, they are giving the antihypertensive. So that is also an option with us. And now, after stabilizing the patient, now we have to decide what we have to terminate. There is a no doubt. Whatever be gestation age, we have to terminate the patient. So now coming to whether trial for the normal vaginal delivery or cesarean, definitely vaginal delivery. We have to look after the score, and we have to induce the patient for that, because the fetal heart rate is okay. We have to give surveillance to the fetal heart rate, and if there is any problem with the fetal heart rate, we have to take the patient for the cesarean. Now this is whole the plan of treatment for that.
Absolutely. I am so grateful that you told everything so well. What is very important as a message here is definitely use magnesium sulfate, whichever regimen you are comfortable with. You can give it IV Pritchard's regimen. You can give the Zuspan. You can give through the infusion pump. Secondly, any cost, you are going to bring down her blood pressure and then only do an attempt at delivery. You should try and deliver her vaginally as much as possible, because it is known to cause less morbidity and mortality. However, you should not unduly prolong the labor, and therefore the delivery, if it gets prolonged more than 12 hours, you may have to take a recourse of doing C-section. And of course, if the blood pressure is uncontrolled, there is fetal distress, there is abruption, or there is an obstetrical indication, you may consider doing a C-section. Now, I wanted to ask you also a little bit in retrospection, Apurba, that is it always magnesium sulfate, or would you want to give something else? Because I am seeing, we having a referral center, sometimes many practitioners still go and reach out to diazepam. What is your take on that? Should we give diazepam or should we directly give magnesium?
Definitely. If it is an eclampsia and if it is not the status epilepticus, then definitely magnesium sulfate is the drug of choice. There is no doubt about it.
So this is something which we want to just assert very well, that don't get scared. Definitely give the loading dose of magnesium sulfate. And maybe if you are giving IV, all the more better. But if you are giving Pritchard's regimen, you may land up giving the entire 14 grams, and then your lab test may come. There can be some renal insufficiency. Don't worry. These patients do not get into any kind of a challenge because it is a very safe medicine in that particular dose. Point number one. Point number two, don't reach out to diazepam. And then, of course, as Apurva said, if it is status epilepticus, then you may have to consider giving her lorazepam or many other alternatives, which are something that we should know the dosages. And the simple monitoring for magnesium sulfate is just looking at the knee jerks, respiratory rate, and urine output. I think we have finished and given the right messages with this case. Should we wind up?
Yeah, Girija. Thank you so much.
Thank you.
Yeah.
Thank you so much, ma'am.
Take
Thank you.
expert comments from Dr. Dr. Nutan.
Nutan, are you here?
Yeah, I'm there.
Yeah.
I think we've covered everything inside.
Yeah. So thank you. Let us.
But as we said, we need to give MagSulf. That is the message. And we give, whichever way you give, MagSulf will protect. So we just need to give MagSulf.
And ma'am, why I am still consider it as a Pritchard regime? Because in Pritchard regime, we are not have to, for the monitoring of the magnesium and everything. So even in a small setup, even in a periphery, the ANM and the health worker can do it. Initial give the treatment and send it to the higher center.
Absolutely understand what you're saying, Apurva. But we are also in a forum where we are all consultants and we have good birth facilities. So we can consider giving an IV regimen and giving it through the infusion pump for better safety of the patient, one. And sometimes if the patient is very sick, has thrombocytopenia, then you may not be wise in giving the intramuscular Pritchard's regimen. You will have to consider giving it through an IV infusion. Exactly. So yes, what you're saying is right, that do not get worried about giving, but sometimes, intramuscular injections, as my experience goes as a JR, fortunately for last so many years now, 25, I only give IV magnesium sulfate. But I have seen that patients have abscesses, issues. These also are very important. And when we are looking at, progressing in doing things, we can very well use the syringe infusion pumps and get used to it, because there's so many medicines which we give through it. Even if you're going to give fluid to your patient of preeclampsia, anemia, heart disease, or one who is in shock, you can very well use these infusion pumps and try to avoid complications because of unmeasured fluids or unmeasured drugs given to the patient. You are saying is absolutely right, because that's what the WHO recommends, because then it's easily accessible. You don't have to wait. You can save the life. Okay. Yeah.
Girija ma'am, it was really nice as usual preeclampsia from you. I just want to
Sachin, tu to ekdam badal gaya.
Thank you, ma'am. I just want to highlight one thing. Everybody gives only the loading dose and leave about the MagSulf. But we have to continue the MagSulf for 24 hours. That is very important. Everybody should remember. People they give loading dose, either they refer the patient to the tertiary center or they just forget about it. But continuing MagSulf for 24 hours, either IV or IM is very important.
Yes, Sachin. And Sachin, I must tell everybody here is a young practitioner like Apurva also. Very dynamic people. And especially Sachin works in the periphery of Mumbai and does a lot of high-risk obstetrics. He keeps on sending me messages, Madam, iska kya karu, uska kya karu. Congratulations, guys. I can see that you all are going to take the maternal health care to a better height.
Yes,
thank you. Thank you so much. With the blessings from seniors like you, Lakshmi ma'am, and others. Definitely, ma'am.
Thank you. Thank you, Lakshmi. Thanks a ton.
Most welcome.
Thank you so much.
Thank you so much. Jyoti, let us move on to the second case discussion.
I will join from my phone now. Huh? Bye.
Yeah. Second is, I think, Savita. Maternal sepsis is, Savita, please start your case discussion.
I let me allow to share my screen.
Yeah, you can. You are allowed. I can't see Savita. Is she? Yeah, Savita.
Okay. I will start from the beginning. Yes. So, first of all, I am thankful to Dr. Lakshmi for giving me this opportunity to present this, moderate this very important topic, which we come across day-to-day practice. And today we are going to share our experience, what we are using in our country. So, this is the case-based discussion on maternal sepsis, and I am going to start my first case. She is a 3P2, 37 weeks pregnancy, presented with excessive discharge, PB for 48 hours, mild pain in lower abdomen for 6 hours on clinical examination. Her BP was 100/60, her pulse respiratory rate was 24 per minute, temperature 100.6, PO2 96, and it correct abdominal examination showed uterus 34 weeks, pelvic presentation, FHS about 110. Mild uterine contractions were there, tenderness were there over the lower abdomen, and there was a foul smelling discharge. And on PV examination, it was of 2 centimeter, 20% effaced, memories were absent, and what is for that? A 2 station. It is not moving. It is not moving. Why? Yes. What is your diagnosis, Dr. Supriya? Dr. Supriya,
Yeah.
are you here?
Can you hear me?
Yeah.
Okay. From whatever key points that I get from the history, definitely she is a woman who has signs and symptoms of premature rupture of membranes.
Yeah.
And premature rupture of membranes has subsequently led to infection. So she's definitely infected. And what we would now want to know more from the history and her findings, whether she is heading towards a sepsis.
Yeah. Very well said, because she's having temperature, her pulse rate is also high, and there is a
BP is on the lower side.
Yeah, foul smelling discharge is there, and there is a tenderness over the lower abdomen.
Lower abdomen, yeah. Foul smelling discharge again.
Yeah.
So all these definitely go in favor of uterine infection.
Yeah. So she is a clear-cut case of a chorioamnionitis, and it is the infection of placenta, chorion, amnion, amniotic fluid that we all know. Then what are the organisms which are responsible for chorioamnionitis? Can you please tell me?
Yeah, definitely. Actually, Madam Nair's talk has made our discussion very easy. She has more or less covered most of the points regarding this topic. But then I would like to, stick to what we would like to diagnose and treat in low or poor resource settings in majority places that we practice in India. Now, we know that the most commonest causes of chorioamnionitis are the bacteria, and what is closest to the genitourinary tract is the gastrointestinal tract. And E. coli, which is a common, a commensal of the gastrointestinal tract, is going to be one of the commonest organism which infects. There are also other group of organisms like the streptococci, the staphylococci, the urea plasma, mycobacterium, listerial organisms. So these are all, Klebsiella. These can also cause infection. We should also be vigilant about the non-bacterial infection, especially with COVID just around the corner. We should be looking for viral origin, for fungal origin, for parasitic origin.
These
especially
fungal infections,
though they are of course very rare,
not very common, yeah.
But in our country, and especially if we are dealing with immunocompromised or HIV positive patients, we should be looking out for those.
So because that's why we should always look for the asymptomatic bacterial when the patient is coming to us for the antenatal checkup, because chorioamnionitis is not common only in those patients who are having the PR1, but also common in those patients without this PR1. So we should.
In fact, madam, there are some studies which indicate that the PR1 in the first place occurs because she has infection.
Yeah, that's the
main pehle ya anda pehle wala jo mamla hai ki whether her PROM has caused the infection or the infection has caused the PROM.
That is also one important cause of PROM infection. Infection is also one important cause. So what are the investigations would you like to do, Dr. Sachin?
Yeah, ma'am, I would like to divide the investigation for three things. First, I would like to do the investigation to rule out the cause of the chorioamnitis. Second thing, I would like to see what is the present condition or the severity of the chorioamnitis. That is second. And third, what is the complications, what the chorioamnitis is causing to the patient. So first thing, I will rule out the cause. I will take the high vaginal swab for this patient. Then for the actual condition of the sepsis, I will do routine CBC, urine culture, blood culture, RFT, LFT. These are the because you have to rule out the multisystemic involvement of the chorioamnitis. And along with that, I will go for the PT, APTT also to rule out, any DIC symptoms has invaded in this patient. So I would like to do the multisystemic involvement also. So, and along with that, if time permits, if she's not in labor, for the fetal investigations also, I will go for the ultrasound with the Dopplers.
If it is not available in your premises, so you can go for the NST also.
NST,
Yes, this patient is having her pulse rate is higher side, but her fetal heart rate it is on the lower side. It means she might be having fetal distress. So we have to go for the NST. And the investigation is done. Hemoglobin was 9.6, TLC was 18,200. And platelets were only 95,000. LFT serum proteins were 5.8, PT was 1.02, and bilirubin was 1.2, and OT, PT, and serum electrolyte phosphate were marginally raised. Although our RFT was normal, and our urine showed only 3 to 4 pus cells, blood culture, HbS sent, and our other investigations show that lactate was normal, that is 1 millimole per liter, and CRP was 56. And her NST showed the sinusoidal pattern. How will you manage further?
Ma'am, when the NST is showing sinusoidal pass, then see what we actually manage the sepsis is the first thing we have to go for the fast. That is a fast AM regime what we use. So we have to first rule out the cause, and we have to take out the infection source. So I think in this case, the delivery is the most important thing what we have to carry on. So if there is a sinusoidal pattern, so there is a baby hampered is there. So I think we will go for, ma'am, PV, she's 2 centimeters dilated, right?
Yeah.
She's 2 centimeters dilated. If it's a well-effaced cervix, then now it is not a very severe sepsis. So I think we can go for induction of labor in this case. That is my opinion. And then we can go for induction with pitocin. If she's 2 centimeters, then we can give a trial for 6 hours, because always vaginal delivery will be much better in this case as sepsis is setting in. That's what is my concern. As she's multi-gravida, she's gravida 3, para 2, 2.
What is
Even I agree. If she is under good antibiotic cover, she is a good candidate for vaginal trial.
Yeah, because she is in second, mild sepsis, moderate and severe sepsis. She is somewhere in between the moderate sepsis, not in the septic shock syndrome.
Correct.
Not in the septic shock syndrome, but the fetal heart that was showing sinusoidal pattern. Is it indication for this normal vaginal delivery?
Madam, I personally, what I would tell you, what I would do in my small nursing home, start her on antibiotic, give her good oxygen and IV fluid, and see at the maybe repeat after 15-20 minutes or half an hour, check whether the NST changes are reversing. Often when the mother's condition starts stabilizing, it is likely that it may be a temporary reaction of the fetus, and the fetus may also, and then of course a big thing to do is to counsel the patient's relatives and the patient that we are dealing with a suspected sepsis, and LSCS may be an easy way out for the baby, but may not be the easiest way out for the mother. And
yes,
therefore,
we have to counsel
so we have to weigh the risk versus the benefits.
We have to
and if the relatives wish to not take any risk, then maybe consider a cesarean section.
Yeah,
However,
because
with a word of caution that in this case, I would prefer the cesarean to take place in a tertiary center and not in a small nursing home.
Yeah, that should be the option, because she is having leaking for more than 48 hours. So chances of fetal pneumonia and infections are very high.
Yes.
So we have to counsel the patient if she wants to take any risk of the fetal risk, or if she wants to go for
Absolutely.
cesarean or vaginal delivery. If she is not ready, then we have to shift her to the tertiary center.
Tertiary center. Yes,
Yeah.
ma'am. Yeah.
So what are the sepsis 6 care bundle? If patient comes to you, at what will you do in such patients?
Okay, first and foremost, 6 care bundle, along with it, the other things also we will discuss. That first, when patient arrives, we have to see her vital parameters, start oxygen and an IV line. You know, this is, in fact, this is what we should even counsel our staff, that if we are not present on the scene in a small nursing homes run by a single obstetrician, not necessarily doctor is present. So this is the list that the even staff member should do, is first start oxygen, start an IV drip for her. We need to assess how bad is her hemodynamic condition and accordingly give fluids. According to the 1 hour bundle, the guidelines that have come, that before starting antibiotics, if possible, draw blood for blood culture.
Yes.
Then
Yes, we have to. We
Yes.
have to withdraw the blood at the
blood
same
for
time
blood
that we
culture
start
at admission. We need not wait for the culture report to come, and we should start broad spectrum antibiotics if possible, and if our city allows it, get a lactamase lactate measurement done. Maybe not available in certain setups, but simple thing like
Is it
urine
available
measurement.
in your city? Is it available?
No, ma'am, no, not in emergency. Maybe in routine hours, not in emergency. I am in a sub-rural, suburban area, B1D. So we don't have this facility in the night time, and such emergencies usually land up in all odd hours. So, but simple thing like measurement of the urine, measurement of, yes, I'm coming to that. In the other parameters that we can measure for a diagnostic and prognostically, which are simple and easily comparatively available, is doing a urine output, measuring her vital parameters at a proper interval. We can ask for serum creatinine and liver function test. Now, this is something even basic laboratories can give us. So if lactate is not available, at least go for these basic investigations.
What else?
Ma'am, actually, there is one more thing. We can go for Mio charting available everywhere.
Yes.
We can make
That is
Mio
another
charting.
thing. According to that, you will put the patient whether she is in sepsis or not. But
Yes.
how will you follow whether this patient is improving or not improving? What test you will like to do for that?
Meow scale, you can go for a SOFA scale, and then you assess the patient.
That is the CRP. That is available, very much available.
Okay. Blood investigation wise, CRP, yes. And it is a good prognostic marker.
CRP and blood lactate level also, ma'am. Blood
lactate level is
blood
not
lactate if not available. Yes, I
because
totally
we are
agree
in
on that.
poor country.
Yes, I totally agree on that.
That's why CRP is the better choice for you people.
And the rule of the
So
thumb
this
is
is the
to
modified
start treatment.
warning system chart.
Yes.
So we can put whether this patient is in a sepsis or not.
Yes.
Okay.
The rule of the thumb is to start treatment as soon as possible, within 1 hour of the diagnosis. And there are proper studies which show that for every hour of delay in treatment, the risk of mortality and morbidity rises by 7 to 8%. It's a very high risk.
Very well said. If you are not giving her proper antibiotic, then mortality rates increases by the 7 to 8%. That is where. Then we have done this, that she is in the prolonged rupture of the membranes, foul smell, discharge is there, pulse rate is high, and respiratory is also 24, temperature is high. So this is the she is in the sepsis. We are not going to discuss this SIRS, systemic inflammatory response syndrome, because these are not very much specific tests. These are although sensitive but not very specific. This has been said, if more than 2 criteria is there, then patient is in the sepsis, or there is a Q SOFA, that is quick systemic organ failure assessment, that is respiratory rate is more than 22, or systolic blood pressure is less than 100, or altered mental condition, or that one is the obstetrically modified Q SOFA also there, in which the respiratory rate has been taken to 25 breaths per minute, because in during pregnancy, patients, because of the physiological changes, there is some increase in the pulse rate as well as the respiratory rate. So it is a modified this QSOPA, and so we are not going to take this. What are the guidelines for infection prevention by the WHO for our country? Because we are the poor country. So what we should do?
Hand sanitation, ma'am, it's very important. Hygiene, then antibiotic prophylaxis, then repeated
to whom
PV
you will
be
give
avoided.
this antibiotic prophylaxis? To whom? Who are the patients to whom you will advise to give the antibiotics?
Yeah, okay, Sachin, you can take it. Yeah, please.
Yeah, all patients of PROM you can give, especially with the diabetic patients, the patients who are in the labor for more than 8 hours. The hypertensive patient, then we can give antibiotic. Obese patients also we can give, but generally in labor patients, when they land in PROMs, we give antibiotic, ma'am.
In case of PROM, in case of operative or cesarean deliveries, in case of, like you said, rupture of membrane more than 6 to 8 hours duration, premature rupture of membranes, in women who are poor socio-economic and poor
especially
status of condition, general condition like anemia,
30.
hypovitaminosis, these kind of patients definitely should receive.
And if you are suspecting the septic abortion also, then we can.
Yes, definitely. Septic abortion, even mastitis, which comes under the purview of many times our patients come to us only with mastitis. So though these are definitely the ones which should start antibiotics.
What about asymptomatic bacteria?
I definitely treat, madam. It is one of the commonest cause of PROM. It is a proven cause, and definitely, and this is something that that's why at 28 weeks, and what normally we do in practice is we investigate once at the time of the first visit, and in poor resource setting, then we don't want to burden the patient again with repeated investigation. But it is a good practice to repeat CBC and urine at 28 weeks and 36 weeks minimum. At least 2 more visits.
Not only routine, but also we have to go for the culture, because so many times the routine test not shows any this buses, but patient is having UT, this asymptomatic bacteriuria. I have found so many patients.
Ma'am, acute pyelonephritis is one of the very dangerous condition, which I have seen 2 patients. They directly landed into acute pyelonephritis during pregnancy at 22 weeks period of gestation.
So how will you train your staff to maintain hand hygiene? Can you tell me?
That is one big challenge, trying to train our staff normally. Number one, because they are usually untrained, they are school dropouts, not very highly educated, and they don't understand the meaning or the importance of hand hygiene. So they should be given some important pointers that when they should compulsorily do hand hygiene. So first and foremost, they should be told that before examining every patient or baby, before handling patient or baby, they should wash their hands with soap or with either some scrub, betadine scrub, or whatever is the practice in that hospital. Secondly, every time they visit the toilet, whether for small job or big job, they should wash their hands after they come outside the toilet. That third thing, whenever they are scrubbing up for any delivery, cesarean, any procedure, they should properly practice hand hygiene. And same thing we can also tell our patient, which I always tell our patient also, that prevent handling that for neonatal sepsis, handling of baby is equally important, and hand hygiene is important for the patient also. So explain to patient also, every time they handle the baby, they should wash their hands with soap and water, and don't allow too many people to handle the baby. 1 or 2 people should be in charge of handling the baby.
Ma'am, here I would like to say, really thanks to Foxy Manyata, because Foxy Manyata, they are doing wonderful job for the training of the sisters in hand hygiene. So they have got nice mnemonics how to wash the hands, and that hand washing should be minimum for 25 to 30 seconds. There are 9 steps. They have nicely did a mnemonic, and they can they
Dr. Sachin, let me just let me know how what interval you will like to do PV examination of your patient. And
see, if the patient is in latent labor, if the patient once we have diagnosed the patient is in latent labor, I will not touch her unless she starts getting good contractions. And in active labor, minimum every 4 to 6 hours only I will reassess her in labor, not less than that, unless there is some indications like there is spontaneous rupture has happened, and there is meconium, or there is some signs of distress has seen on the monitor or by the auscultation, then only I will intervene. Otherwise, 6 hours, 4 to 6 hours PV is what we have to practice.
Yeah,
so
there
that
one
is
more
very
one more
important.
point I would like to make here, especially like if we want to make out whether the discharge is turning into foul smell or meconium, what Durusha madam used to always recommend, that instead of doing PV, do a per speculum examination. Use a sterile speculum and put in a speculum and observe. Don't put your fingers in.
And total, not more than 5 times PV should be done during the labor. So that is very important to prevent those sepsis to the women, and that is because because in our country this poor sanitation and poor this hygienic problems are there. That's why patients are dying because of this maternal sepsis. It is the second most common cause of the death. So what antibiotic you will like to give to this patient?
Yeah, Sachin, you'll take it or you want me to go?
Yeah, no, you can tell, no problem.
No, bolo, koi nahi.
Any broad spectrum antibiotic we can give. Broad spectrum antibiotic we can start for as a routine one.
Okay.
You should have you can cover both, like gram positive and gram negative organism.
In routine, if this patient has come to you, what will you give? What antibiotic you will give? This patient has
Monosef. I give Monosef.
Okay.
For as a prophylaxis.
As a prophylaxis, yes, Monosef is sufficient. But if we have a proven case of sepsis or even suspected sepsis, maybe we'll go for. And nowadays we have to be very vigilant about beta-lactamase resistant, and therefore adding a beta-lactamase inhibitor, like something like a piperacillin tazobactam. That is my favorite drug for these kind of cases. Yeah.
This patient is a proved case of sepsis,
Yeah,
so we have
to
go
something like a meropenem and all may not easily be available in our town. It's not easily
that should
available.
not be given as a first choice. That should
that is
be
the second line drugs.
And I personally am of the opinion, even if I give a broad spectrum, I always add metronidazole and amikacin. That's my personal choice.
So, IV fluids were administered, and ceftriaxone, metrodin, and gentamicin was given. Fresh blood was arranged. Would you like to arrange fresh blood or not in this patient?
Definitely.
Yes.
Yeah. And because patient was not ready to take any risk for the baby, although she was waiting for 48 hours at her home, but now she was not ready. So her LSCS was done at a tertiary center, and baby delivered was the female baby with Apgar score 2, 4, and 6 at 0, 5, 10 minutes, and it was shifted to NICU. And although her this lactate was done because she was in the ICU, so it was 1 millimole per liter, and after 24 hours O2 was removed, patients were to settle. So if we go for the proper treatment at the proper time, the chances of developing septic shock are very less. And we have discussed all these things. When will you like to shift her to the tertiary care center? If any patient has come to you in sepsis, you look the case of, then when will you like to shift her to the
as soon as patient arrives, first and foremost, we have to try and stabilize her hemodynamically. So Madam Nair has already mentioned that we will be starting her on crystalloids. Sometimes we are tempted to use colloids, but nowadays it has been quite clearly proven that colloids don't give any advantage over properly infused crystalloids. So that should be our first and foremost aim. Nasal oxygen, start a high, a broad spectrum antibiotic on her. The need for transfer will have to be taken depending on how much is the facility available at your center. If we are in a small center where there is no ICU facility, definitely she is a candidate for transfer. If on giving basic measures like crystalloids, or maybe sometime we may have to give even vasopressors, but if she needs vasopressors to keep her BP up, that is definitely one more indication she needs to go to a higher center. And this assessment has to be made by a senior consultant. We cannot leave it to the juniors or the residents to make the decision, or the nurses. Definitely the senior most doctor on the scene has to go and have a look. And we should be looking at the cause due to which she has sepsis. Now in this lady's case, it was due to chorioamnionitis, and so obviously once the baby is out, the source of infection is out, she is going to improve. But if it is some other cause, say like for example, like I mentioned, mastitis, then we should think of doing an IND of the abscess. If she has some retained products, we may want to evacuate those products. If the infection is severe, there's a collection or some pus inside the abdomen, we should consider draining that. On monitoring, if there is deterioration of the patient or there is no stabilization within first 4 to 6 hours, I think she should be transferred to higher center.
Yeah, I will, ma'am, I will just see all the parameters. If there is no involvement, if there is no multi-organ involvement in the patient, if PTINR everything is normal, then I will keep with me. If is there any involvement, if the creatinine is rising, if there is involvement of liver, and if PTINR is deranged, platelets are very low, then better I will take her to the higher center and then I will deliver her. I just want to highlight one point here, ma'am, regarding the antibiotic therapy. In cases of chorioamnitis, we have to continue the antibiotic for 5 days in these patients postpartum. That's what I feel.
Yes, yes. In fact, recommendation is 7 to 10 days.
Yeah. Yes, yes. We have to give antibiotic, proper antibiotic, and
Correct.
explain the patient. And after that, we have to give oral antibiotics and follow up the patients.
Because sometimes these patients comes late in a ARF because of the infection.
There are a lot of minor issues like lactation failure, all things are there in the cases of sepsis. So we have to tackle those issues also.
And also we should be looking out for neonatal sepsis. So the baby
Yes.
needs to be properly monitored by the pediatrician. Yeah.
So take home message is take the that is wash, that is hand hygiene and water sanitation, then until recognition of asymptomatic bacteria. We have to treat the anemia timely. And if you suspect the sepsis, within 1 hour of suspected diagnosis, obtain culture and serum lactate, administer broad spectrum antibiotics, initiate fluid therapy up to 30 ml of per kg of steroid initially to maintain MAP, mean arterial pressure more than 65 millimeter of mercury. A lower value may be acceptable in pregnancy, individualize it. And start the BP, the MAP is less than 65 millimeter of mercury, then we have to start the norepinephrine. And also we have to start low dose steroids in if the no response to norepinephrine is there, and achieve early source control, that is use imaging studies as indicated, and consider electrical fetal monitoring the babies less than 24 hours pregnancy, and consider steroid for fetal maturity after the 23 to 24 weeks of the pregnancy. So early enteral feeding, initiate DVT prophylaxis also, and avoid hyperglycemia above 180 milligram per deciliter. I would like to take comments from our expert, Dr. Deepa.
Yeah, Deepa. Deepa, are you here with us?
Yeah. I think it's all been covered.
Please stop screen sharing. Yeah, thank you so much. Yeah, Deepa.
No, I think it has all been covered very beautifully through the case presentations.
Yeah,
I think the single thing to reiterate is prompt recognition and institution of treatment within an hour.
Thank you, Deepa. Bhavna, please start with your case.
Good evening, ma'am. Good evening, Lakshmi ma'am, for giving me this opportunity to be on this so much prestigious platform. And I congratulate you and all this foreign faculty speakers. All the things are very, very nice, particularly the simulations and the drill videos. Thank you so much, ma'am. So I take here the case-based discussion of impacted fetal head. And I have very senior panelists with me, Dr. Kanchan ma'am and Dr. Pratibha ma'am. So I hope my screen is visible and it's clear.
Yes.
Yeah, okay. So we have a case here. Sarah, she is a 19-year-old mother expecting her first child, and she lives with her family in rural areas, and she just got married at 18 like most of her friends do. So she has her whole pregnancy that was taken care of at primary healthcare center, and that was absolutely non-complicated. So she was being taken care of there. Now she goes into spontaneous labor at 39 weeks. And she has been laboring for 2 days, partly at home and partly at the center. And finally, because of extreme pain and the prolonged labor, that prompted the Sarah to transport it to the nearest tertiary care center. So on examination, the general condition is very fair. Pulse rate 104 per minute, blood pressure 170, respiratory rate is slightly high. Temperature mild, 100 is there, fell off, plus patient is dehydrated. On per abdominal examination, uterus is full term, tense and tender. Contractions are there, three contractions in 10 minutes, and each contraction lasting 45 seconds. Fetus in longitudinal lie, cephalic, no pole is palpable. Fetal tachycardia is there, 180 beats per minute, and it is regular. Vaginal findings are fully dilated cervix, fully effaced, vertex at +1 station, left occipital anterior, capitis plus and molding is there. And vagina is definitely hot, dry and vagina. Liquor is completely drained. Patient was diagnosed as a case of obstructed labor. Immediate management for resuscitation and stabilization is started, and call for help, IV line, blood sample for cross-match, antibiotics, all the basic things we have done because we are going to focus predominantly on the operative part. So category 1 cesarean section is decided. So what are the challenges we are expecting in this surgery? Pratibha ma'am, please, can you comment on
that? Good evening, everyone, and thank you so much for giving me this opportunity, Lakshmi madam and Dr. Jyoti. So this patient actually has been handled outside, and she is already in labor, and she has cervix is fully dilated. There is a big caput, and the vertex is at +1 station. So no pole is palpable per abdomen. So the challenges which we are will be facing here during surgery is the delivery of the impacted baby, especially the deeply impacted head. So that is the biggest challenge we will be facing during delivery. And with that, when we will be delivering the head, there may be chances of extension of the uterine incision or the injury of the adjacent organs like the bladder and the urinary tract. So you must adopt some correct surgical techniques so that you can disinfect the fetal head and you can take out or deliver the baby, this jam-packed baby, from the uterine cavity.
Yeah, ma'am, absolutely correct. The biggest challenge we are going to face here is the deeply impacted head, as we can predict it from the scenario. And definitely there are few things which we can do for this patient. So deep impacted head is the foremost concern, and this is compounded by the absence of amniotic fluid and a tight hug of the uterus on the fetus, reducing the room for manipulation of fetal parts. So Kanchan ma'am, can we predict, and if, like we are predicting here that this is, so what actually the definition of impacted head is when we say that this is an impacted head?
First of all, thank you very much, Dr. Bhavna, for moderating the session so nicely. And my sincere regards and thanks and congratulations to Lakshmi ma'am. In fact, I am very much fond of her, and she is a perfectionist. I really love her presentations. I have heard her in past also. She's a perfectionist, ma'am. Thank you very much for giving me chance. Ideally, the deeply impacted head is the head which is impacted in the pelvis, lodged deep in the pelvis, and that needs certain maneuvers during the cesarean section, maybe depending on case to case, that may be push, pull, or different techniques that we will be discussing in further discussion. Yeah.
So already, as our expert has already mentioned, that there is no clear-cut definition, but yes, as Kanchan ma'am stated very rightly, that any cesarean birth which requires some additional techniques to disimpact the fetal head, whether it can be a prophylactic thing where we are predicting that it can be impacted head, or if the surgeon deems there is a difficulty in delivering the head. Complications were very well discussed by our experts. With mother, there can be complications of damage to uterus, urinary tract, PPH, long hospital stay, hysterectomy, and for babies, skull fracture, intracranial bleed, nerve injury, hypoxic brake damage, and neonatal death. So Pratibha ma'am, can we have any risk factors or some scenarios where we can predict that this can happen so that we are prepared beforehand?
Yeah, actually, if the patient is priming and if she is, the baby is big size baby is there, and if during when she is in labor, if the cervix is fully dilated and the caput formation is there, and if you are suspecting some malposition like occipito transfers or occipito posterior position, in all those cases, sometimes you can predict that there may be the chances of outlet obstruction and there may be deeply impacted fetal head. Then when you are doing oxytocin augmentation, in that case also, when the head is not coming down and you are not, the delivery is not expediting. So in that case also there may be you can suspect. Then when you are trying for any operative vaginal delivery, either vacuum or forceps, if you're normally, what we have seen many a times, people tend to put vacuum and they are failed in that. So that is also the indication that maybe this patient is going for obstructed labor or a deeply impacted head, and you may need to take her for surgery. And sometimes it is because of the inexperience also, like if any junior doctor is conducting the delivery and they are not aware of the CPD, or because of the big size forming. So that all should be taken care. And if these are the risk factors which may result into impacted head.
Yes, thank you, ma'am. Very correctly enumerated. You have all the factors. So there are certain scenarios which can be like patient in deep transverse arrest. If you are taking up cesarean section for these scenarios, you should be more like taking care of this. There can be impacted head. So deep transverse arrest, occipitosacral arrest, acute fetal distress in first stage of labor with head deep inside the pelvis, unanticipated cephaloparablic disproportion late in labor, or cervical dystocia with the head deep in pelvis. So in these scenarios, we can actually think of this. Kanchan ma'am, would you like to tell something? What preparations when we can do? Like we have this scenario, and I think we are anticipating impacted head.
Yes, Bhavna. First of all, when we anticipate impacted head, first of all, these things to be done at a tertiary care system, and full team should be prepared, and well conversation with the patient should be there, well counseling should be there, pediatrician should be there, your team and the senior gynecologist should be there, because you should properly explain to your patient that these complications can happen. Can there be extension of the incision, maybe tear, may patient go in PPH, and many other complications which we have. And the manures, you can explain, somebody from your team can explain to the patient. So that you have, first of all, alert your team. You have to lower the table so that your approach is better. So you try an incision while you are giving, that is, as was discussed, is to be given slightly higher, or may you give a slightly J-shape incision. And in case, as was discussed, fetal pillow can you can judge it, but I don't prefer it. If you judge and you have to push it up, push head, you can keep prepared fetal pillow. I have never used in my practice. This is discussed in theory.
Yes, ma'am. So that was a very clear thing, that if you are anticipating, it's very good that we have to counsel the patient. We have to make our team prepared for all the emergency, because any complication, if it happens, that has to be mentioned then and there. When we are prepared, we are definitely going to deal it better. One more thing, one more point I think we can add here is that if at all we are planning to use the disinfection by the push method, then that can also be done prior to giving incision for the cesarean section, if we are going to prefer that method for this patient. So now looking at these scenarios, how would you like to manage this patient according to your experience? Pratibha ma'am.
Normally there are many maneuvers, like if we have already thought that this is a deeply impacted head and head is jamly packed inside the uterine, in the pelvis. In that case, what I am practicing most of the time, I am doing Patwardhan technique, and for that, the incision which I am giving on the uterine, on the lower segment, is a little bit higher up at the level of somewhere around the shoulder. It comes around that only, and I try to take out the baby through Patwardhan technique, where we have to first pull the shoulder which is coming in front first, that is anterior shoulder, then the posterior fourth shoulder. Then you can flex the body and can ask the assistant to put the fundal, give the fundal pressure so that the body flexes, and so you can hook the baby's body, and then you can take out the breech or the limbs, and finally you can lift the head from the pelvis. So this is the technique which I am using. And if it is direct occipito anterior, occipito posterior thing, where the limbs are in the front, in that case you can just do the reverse breech
extraction also, that is also we can do it.
Yeah,
So
sure.
these are the two techniques which I am using. Push technique, normally I have not used, I have never done that, but that is what we have just discussed so much. And I think we don't have that type of team which can just give that push, which should be done properly, which Dr. Dipali was telling, that it should be in the cup manner and then it should be on the lateral side so that you can just dislodge the vacuum in that. So that is also is a technique you can do. But I'm doing Patwardhan technique and I'm very much comfortable with that.
Kanchan ma'am, your experience also in this?
Actually, because when this type of condition is being faced, then first of all, I used to judge whether the fetus is in occipito anterior or occipito posterior or in deep transverse arrest. So depending on my judgment, if fetus is in occipito anterior position.
I think first we can talk of occipito anterior, then we come to
then occipito anterior, and how did it's true that I prefer the pull technique rather the push technique. And in pull technique, because in occipito anterior both the shoulders are there, hooking the shoulders, I deliver both the shoulder, then I give a gentle traction and delivering the breech, and then delivering the head out. That is the Patwardhan maneuver. And if it is in transverse arrest, deep transverse arrest, then first of all delivering the one shoulder, then the other shoulder rotating, and then the breech, and ultimately later on the head delivery. And if it is occipito posterior position, then it's comparatively more simpler by holding the breech, both the legs. If they are flexed, they are better to hook and deliver by the breech extraction, limbs, then trunk, then head ultimately. And that is very easy. By these maneuvers, I touchwood never had any problem. I had many cases of deep infected head, but they deliver by this method very easily.
So our panelists definitely would like to go with the pull method. So they are quite biased with that. So, but just to enumerate, because all these methods can be done, and we'll certainly like Dr. Dipali's also view on that. But just to enumerate, the cephalic extraction, just put a flat of the lower hand between the uterine incision and the fetal head deep into vagina and slowly push the head out of the pelvis with the fingers. For this, I'm already, Dr. Dipali already told that we have to go from slightly from the lateral side so that we can do that. Avoid too much leveraging because it can lead to extension into lower uterine segment. What are the problems which we can encounter here is difficulty in reaching the head lower down, and there is a thinned out segment, so more chances of incision going downward, and it can involve uterine vessels also. So to help here, we can put the patient in semilithotomy and we can try to disimpact the head with the help of the assistant. But the main safety point is you have to use the complete hand. The assistant has to use the complete hand, not the fingers. If he's using the fingers, then it can lead to fractures. So that is the increased risk of fetal trauma which occurs here. This is a small clip from the prompt trainings only. Oh, sorry.
Just now can share the video.
Yeah. Just a minute.
For push technique, I think we have to be prepared from beforehand, because we should have some assistant previously ready to do that.
The expert
senior that is very important.
Yeah.
That is very important.
Somehow.
Just share your screen. Share your screen first.
Just a minute, ma'am. Actually, I just wanted to bring down the video, so just a minute.
Madam, can I make a quick statement till then? Just an experience I would like to share with this deeply impacted head. When we do Patwardhan's maneuver, we have to be careful because I personally had two experiences. In fact, one baby actually I had a fracture humerus while delivering by Patwardhan's technique, because it is not as easy as it sounds or looks when we actually do it, because normally We are dealing with a very hefty baby who's stuck inside. And that's why delivering the baby, even by Patwardhan technique, we have to be extremely careful how much pressure we apply. And in my younger days, I've done that, fractured humerus once and fractured clavicle once of 2 different babies. So this is something that you have to be very careful.
Trained enough.
Yes. And then with time, you know, you get the gauge how much pressure you can apply and how much you should not.
Yeah,
even for bringing the breech down, reverse breech, sometimes they fracture the limbs. That is
Yes, yes, ma'am. And actually, comparatively, assistant giving pressure from below and we trying to flex the head is a much better technique, I feel, compared to if you are not experienced with doing the Patwardhan maneuver.
I don't know why the video is causing some trouble. So we can just, in between, we can discuss about the next, what Patwardhan ma'am was talking of.
Video were moving very well.
Yeah, yesterday we did quite a practice. It was.
Yeah, you can.
No, but today it is not. It is getting closed. I don't know why. So I'm going to skip that because it is wasting time.
I think video is deeply engaged among the slides.
But they were very well moving and showing very, very nicely the extraction and this pulling and all. बहुत अच्छा चल रहा था.
We definitely did a good practice, but whatever it is.
We all are experts. You can give your take-home message.
Yes, yes, ma'am. Just I'm doing that only. I'm trying to bring PowerPoint back.
Yeah.
So now it is not going beyond that.
So it's okay. This was a nice discussion.
No, ma'am. Just a minute. Just a minute. Please. I'm really sorry for that.
No, not at all, Bhavna.
You put it on the next slide and then share.
That is what I'm trying to do now. I'll just go on next slide and
next
then
slide
I will.
And then you share. Yes.
Yes. But somehow it is the same issue again. Ma'am, I'm not going to put it in the slideshow, but because I don't know why it is creating problem in the slideshow.
No problem, Bhavna. Go ahead.
So this is Patwardhans, in which we said both shoulders delivered first, followed by trunk is delivered by flexion and both legs delivered, head lifted out last. So now how to manage if it is occipito-transverse or occipito-posterior. So as already ma'am said, occipito-transverse, we have interior and posterior. Kanchan ma'am has already very well said. So 1, 2, one shoulder, second shoulder, followed by the trunk, reach, and then head. So this is occipito-posterior because in this the back is back. So we have to do the reverse breech extraction. That is what we do. Again, I had this.
Yes. It's going. Running. Breech extraction, reverse breech extraction. Yeah.
So as we had a good talk that what is pull or push, what is better. So these are the studies What does the evidence say? Pratibha ma'am, would you like to comment on that?
Evidence is that the pull technique is better, although push technique is also being used, but as far as fetal complications are occurred, they are similar in both the conditions. And with the push technique, if you are well versed, maybe sometimes there are extension of the uterine incision. There may be sometimes tear in the lower uterine segment. It may extend up to cervix or up to vagina also. So this may cause a lot of bleeding, and sometimes it may extend laterally also and may result into hysterectomy. So that is the only complication which is normally seen with the push technique. If you have good experience with doing that, you can do it. But push versus pull technique, not very much difference as far as fetal neonatal outcome is there. So that
yeah, neonatal injuries are seen as same. In both the cases, but definitely maternal. Few studies do go with that maternal complications are better, more in this. So Kanchan ma'am, do you also go with this?
Fetal pillow, etc. We are not.
In the literature, there are so many devices are there. Like there is a seat doctor can be used, or there is some 10-port. I mean, it is like a made up of polyethylene. So that can be used just to release the vacuum down. So that type of this fetal pillow is also being used, but I have never used. And I think it is very costly also. That is what been told by Dr. Dipali. So I think they are not having good experience with that. So normally people are not using. But if at all you have to use, it has to be used before starting the cesarean section.
You should plan beforehand and keep ready.
Dr. already told that yes, there is still not clear consensus whether it is useful in all cases. So NICE also recommends this is the guidance that you have to choose the correct patient for that, and definitely there are patients for that.
It said that it takes longer time also. So sometimes the time is wasted by doing.
I think this video will also move.
So how we managed our patient? We managed by the Patwardhan method. This is what we do: back anterior delivery of shoulders, one shoulder, followed by the delivery of another shoulder, and then the trunk. Breech, and finally last it is the head. Trunk, breech, and this is head.
Right.
So this is how we manage. So as we know that this is a thing which happens certainly it happens in the OT, and that is quite a high pressure zone. Quite adrenaline is being secreted already. So how can we have to be prepared for it beforehand? So how can we improve our skills?
But natural multi-professional training and simulation devices, again training the youngers and keep your team ready as in you people are doing, like training the staffs also. Manyata people are doing, they are doing it in a practical way.
So the most important point here is the multi-professional. It is not just the training of the doctors which will help. It is basically you have to
train your staff.
Your assistants should also be well trained. So lessons learned: impacted fetal head is relatively common and is associated with maternal and fetal complications. Be prepared if there are signs of obstructed labor or low fetal station, particularly if there are malpositions. Alert team if impacted head is anticipated. Calmly declare the emergency if it is encountered during surgery. Request senior obstetric help. Step-by-step approach and multi-professional trainings. And thank you so much for making our healthy baby.
Sorry. Thank you, Bhavna. Deepali, your comments, please.
No comments. I think she has.
Yeah. So, Nutan, I invite you for your concluding remarks, and then we will wind up. Nutan, please. Bhavna, stop your screen sharing. Yeah. Nutan?
No, I was going to say thank you, Lakshmi and Jyotsna, for firstly organizing this combined. It's very memorable for us as well. Obviously, Jyoti Malik has been doing an excellent job. And all the panelists and moderator. And thank you to all the participants. And I've seen the participant list is going up, so that makes me very happy. And also my colleagues who, given hours of their weekend, which is really important and precious for us. And no, it was an enjoyable experience. And actually, the Patwardhan maneuver, I have learned it before, but we've forgotten because we don't use it. And I think impacted fetal head is becoming more of a problem because, in the UK, we do sort of not push them, but, we do give them more time because of, our having fetal surveillance and continuous monitoring, we are more reassured. And sometimes I think we are in the end, literally stuck. So we've been experiencing that, and actually it's good to learn, and I was happy to see that video, and actually I did enjoy that video. So thank you very much, all of you, and have a nice evening.
Nutan, thank you so much. I really admire and appreciate the passion of teaching and participating in this webinar, because you have really spent your weekend and precious 3 hours for this webinar, you, Deepali and Deepa. So thank you so much. And now back to Jyoti. Jyoti.
Madam, thank you very much. And I want to say one shairi. So this shairi is specially dedicated.
Bolo, Deepali bhi hai, Nutan bhi hai, Deepa bhi hai. Bolo.
This shairi is specifically dedicated to all obstetricians, because obstetrics is a very high energy branch, like Madam just said, very, very high, lot of adrenaline, how much, God knows, maybe by the tons. So this is for all our obstetricians. कि आ रहा है नया जमाना, चल रहे हैं सारे नए दिशा की ओर. आ रहा है नया जमाना, चल रहे हैं सारे नए दिशा की ओर. पूरी दुनिया में आ गया है एक नया दौर, मगर हम ऑब्स्टेट्रिशियंस अभी वहीं फंसे हैं. भाई कर जोर, कर जोर, कर जोर.
Excellent.
So thank you. You can stop recording.